So getting back to this topic, the nullism bias against the consumer for the manufacturer, and how multiplicity adjustment and safety testing expands that bias. One thing that came up in the break was this point. It's something, again, as I hope those quotes from Neyman show you, that you have to understand that statistical methods are based on values, especially if they have any decision element, any dichotomization. You have to make a decision, are we going to continue using this product or prefer another procedure or whatever. They're inherently they have values built into them. The trouble is that people don't see that. Even the statisticians seem to cease to see that, and what gets in place is just default values. Those default values may not be the ones that you would want to use or want to see being used, depending on your stake in the situation. I bring up this multiple testing because I see it in your literature. I see it becoming more and more demanded in the reproducibility crisis, and it's very dangerous because it's based on a bias toward what's sometimes called the universal null. These adjustments embody a strong prior belief that almost all observed associations are pure noise. It's a belief usually based on no data whatsoever. If you thought about what kind of data would be needed to support this universal null, and what kind of biologic theory you would have to have. It does happen. All these statistical tools have their place. They have locations where they're appropriate, but they have to be situations where the values that are built into them apply, as in, for example, genomics, genome-wide association screens, and so forth. Their interpretation usually confuses a decision to ignore association with a belief that there is no association. This is a major problem. And again, Neyman was well aware of this. Both the problems are aggravated by conventional statistical training, including the training of statisticians. In fact, it's so bad that I often find that they're defending the universal null by fallacious statistical arguments, such as if there's no real effect, you will still get significant associations. That's true. Premise 2, people select significant associations. That's true. And then the conclusion that's reached is the selected associations must be null. I have seen that, basically, that reasoning lying behind an article that got a lot of press in the Royal Statistical Society magazine Significance, which is a news magazine of the Royal Statistical Society. It was all based entirely on this fallacious reasoning. You've earlier seen some examples of fallacious deductions. That conclusion does not follow from the premises, not even close. Because that argument, the premises say nothing about the true prevalence of effects, which has to be zero to force the conclusion. The only way that you could know that conclusion would be to know in advance that all associations were null. And if you knew that, you wouldn't have to do any study or any analysis. If the null were always false, 100% prevalence of effects, there would be no false positives. False positives would be impossible. I'm only pointing that out to give you the logical extreme of how wrong that kind of conclusion could be. And even some defenders of testing, major testing, defenders of testing, I think somebody mentioned Deborah Mayo, for example, points that out. That's another example of the prosecutor's fallacy of failing to account for the base rate. But this is a favorite among statisticians, not all statisticians, but some that get press. And in health risk assessment, the universal null is sometimes defended by appealing to dubious contextual or mechanistic arguments. Example, I wonder if anybody has seen this one before. I've encountered it a lot because I've been involved in environmental and occupational carcinogen controversies, as I mentioned, in the magnetic field, and so forth. One such argument claims humans have been naturally selected to resist carcinogens. Now, even if this was true in some sense, it does not apply to the chief controversies of the field. In almost all the examples where litigation abounds, at least one and usually both of the following facts invalidate the argument. the entire class to which the exposure belongs, which is plasticizers, pharmaceuticals, was introduced only recently. So it's a leap of faith to assume our bodies evolved defenses that completely disarm those types of exposures. Then also cancer, which is what's at stake in most of these controversies, is extremely rare until well past reproductive age. So its causes exert negligible selective pressure. Even the cancers most common before and during reproductive ages are rare at parenting ages. With this rarity, there can be only slight selective pressures from the effect sizes at issue, which are generally, always relative risk less than 4. If they're much bigger than that, it's obvious what's going on. So the natural selection argument is only rhetorical seduction by mechanism. Which again, it came up in Roger's talk. We have one dubious null hypothesis, which amounts to selective pressure favored complete resistance to modern carcinogens, touted as if it strongly supports the null. So somebody's speculative theory is now treated as if it's data. That's basically what is going on with mechanistic arguments. And by the way, I like this because analogous comments apply to arguments for paleo diets. You see this in the Mercola site. And also, you see a lot in evolutionary psychology, which is big in some quarters. They're making claims about selection which are just so naive if you work through the actual selective pressure. Now, bias toward null inferences is sometimes defended a little more sophisticatedly with reference to heuristic maxims that are sometimes called parsimony principles, such as Occam's razor. And there's some quarters in which they'll raise parsimony as if it was written on it was one of the lost tablets from the Mount Sinai. It's known among those, again, who carefully study these things, that's ridiculous. It's not some natural feature of the universe. But there is an idea, there is a fact that model simplicity has benefits. Simple models can provide useful data summaries and can outperform some complex models, even if the reality is complex beyond any ability to model it. Okay, but simple models have had a dubious record in causal inference, which I think is what was at stake here. You're talking about what to do to prevent the infections that you're dealing with. Because there's too many possibly important factors for a simple model to capture for inference. And that's why and where randomized trials come in dealing with that complexity by randomizing it and therefore having a distribution to deal with it. Sometimes a simplified model is close enough to reality so that the bias incurred by using it is outweighed by the noise reduction it achieves. And that's the basis for a lot of sophisticated statistical methods that I have promoted and used throughout my time, many decades, penalization and shrinkage methods. It can also have practical benefits. Use of simple models may save time, it enables wider adoption, and it reduces procedural errors, which is one of the major sources of errors that you always talk about selection bias, confounding, this kind of thing. But I found equally often that there are procedural errors, that there was a programming error, data entry error, that sort of thing. In fact, according to one of the original discoverers of the problem with the Duke University trials in Il-Patti, I don't know how many of you heard of the Duke scandal, but for those of you who have, the original discoverer of that commented he thought that the whole thing started with a data error. It was not an intentional attempted fraud. There was a data error that created this. And once they saw it, it was too good to be true. They wanted it to be true. And so they held on to it steadfastly. That was his opinion. So it's good to have simplicity for that reason. And I wish they'd had that in my car. But these benefits neither imply nor require that the underlying phenomena are themselves simple, since they accrue even when modeling transcomputable phenomena like living organisms. So in other words, parsimony is a heuristic that's useful, but mistaken it gets translated into this universal truth and then put in these statistical procedures in that form. So here's the conclusions from this segment. Arguments that null hypotheses are generally true and those arguments are logically fallacious and empirically void. Okay? I mean, I've actually gotten this. I happen to be friends with a well-known, award-winning science journalist, Gary Taubes, and I went around with him many things. It was just he was from a physics background, saying that there's no basis for this. You have this prejudice towards the null. Where's the data? If you're being a scientist, you're supposed to talk about, eventually get back to observations, not what's in your head. We're not in the Middle Ages. We're not Aristotle. We're in an empirical age. So I have an empirical bias. And while predictive and modeling tasks might adopt parsimony as a heuristic, the use of those null hypotheses does not justify belief in them. Belief in them means you're going to now start holding on to them in the face of evidence that's showing that they're not correct, and perhaps causing costly errors. And like all hypotheses, null hypotheses need to be contrasted against evidence and treated agnostically when, as usual, the evidence is weak. You can salvage skepticism by saying you need to be skeptics in every direction. You need to be skeptical against every hypothesis offered, including the null. Yes?
You mentioned the previous slide one quick thing.
I can't hear you.
Go back to the previous slide.
Oh, sure.
When you talk about the simplified model, we're presuming that it's not all-encompassing, but it covers mostly everything, but not everything. Is that what you mean by simplified model, or?
Well, not necessarily. There are formal ways of defining simplicity, but it's one of those things where you can know it when you see it. I mean, a model that has a bunch of terms in it, including product terms. Say we're talking about a regression model. A lot of these publications, right, are using these regression models that have these coefficients. And they can be very complicated, or they can be much simpler just by having fewer terms. So that's what I'm talking about. I don't know if that answer your question, or sorry. Okay. Now I'm going to talk about a few more fallacies that arise. Technical preliminary to those, contrary to what I regard as erroneous traditions and advice, to always use two-sided p-values. And I think Goodman had written some article back in the 1980s, in fact, even promoting that. Was still promoting that relatively late in 2008. But in accord with D.R. Cox, in the following, I'm going to use one-sided p-values and denote by p1, because I'm interested in only one direction of effect, which is the harmful one, which is upward for adverse outcomes. And it turns out, though I'm not going to talk about that it is more easily translated into relevant Bayesian statements about probability of harm. It's not to say that I would always use one-sided p-values. In fact, in the amalgam versus composite controversy, that would be a two-sided situation, because we don't know which one is better. But a lot of situations I'm involved in is clearly one-sided, like with the magnetic fields. We're not concerned about them being good for your health. We're concerned about them being bad for children's health, for example. Now, for relative risk, that means for infrequent outcomes, any of the hazard ratio, rate ratio, risk ratio, odds ratio, these terms you'll see in the literature, they're about the same. The null hypothesis tested then is that the risk ratio, relative risk, is less than or equal to 1. It's not that it's equal to 1. Okay? That's a technical aside, but I'm just explaining the choice here. And then I'll deal with this problem of ostensibly negative reports. And you could contrast what I'm saying here to Ioannidis in 2005 and most everything since. Here's a question. Do you think dentists are qualified to understand the limitations of safety studies? Given what you heard from Roger and what you heard from me now, that even with perfect studies, there are these tremendous problems which statisticians who are honored PhD statistician faculty fall prey to. They're so logically hard to get right. Okay? If you remember that we saw in the FDA webpage, they said, talk to your dentist. Okay? Well, have them take this quiz, or you take this quiz, since you are all are dentists as well. There has not been even one, but suppose there have been 5 perfect randomized controlled trials of the long-term effects of mercury amalgams on the occurrence of tremor by age 70. So maybe we're talking about practitioners, maybe we're talking about patients. All of them found no significant increase in tremor based on exposed, say, area times duration of exposure, which is an index I've seen used in some of the literature. Okay, they found no statistically significant increase in tremor based on that index. Okay, that means that P greater than 0.05. And by the way, for a one-sided test, that's easier to get than for a two-sided. Two-sided test to get P greater than 0.05, that would be P greater than 0.025, half that. So does this evidence, which is far stronger than anything ordinarily available in post-marketing surveillance, affirm the safety of dental amalgam? Because that's what the ADA website said. The literature affirms the safety. Okay? Now you're shaking your head no. Why not?
All it tells you is they don't get a tremor.
Yeah.
What?
One item, that's it. It just tells you that they don't have a tremor. Doesn't tell you anything else. And they have no hand.
That's a good point. How about good? That's a good point. What? It's only in that group. Only in that group. You are all more? Any more?
It just says there's no evidence that we know of that it causes discrimination of tremor. It doesn't say it's not the evidence of that. Yes.
Yeah. Okay, and that's great. I'm going to say that you're all right. And furthermore, even if you didn't think of any of those things, this would still be wrong, just on pure logical grounds. Let me explain. The answer is no. You know that it's no, but you knew it because of subject matter knowledge, which shows you the importance of subject matter knowledge. It can save you, even if you don't know how bad the statistics are. When I say how bad they are, I don't mean badly done, badly computed. I don't mean they did stepwise or something else stupid. I mean that they're bad and that they're hard to interpret correctly, even when you're using, everything's perfect. The statistical computations, your package, your data. Okay, let's do the logic, then the math. Okay, all we are given is that 5 studies with no problem other than random error have a P greater than 0.05. Logically, all we need to show is that this result is compatible with more detailed results that would refute safety. For example, just to take a simple example, suppose the p-values were all 0.10. Then the Fisher summary p-value, which is all I can get out of the p-values, is 0.01. Okay? Now this is the problem. I see this constantly, summaries of the literature, safety statements, so forth, where they say, studies have failed to find. Studies have failed to, or something like that. They say even more, or they affirm this, whatever they say, they're looking at each one. And each one of these studies may have been reported, we found no significant difference. We found no significant difference found, blah, 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 so forth. That could happen over and over again. And in 5 studies, under the null, that would be actually more likely to you wouldn't expect to even have one study that was significant, statistically significant. The problem is the statistics. This can happen. If they were all 0.10, or if their geometric mean of their p-values is 0.10, that would mean that they have found something when taken together. Yes?
Do non-inferiority designs do anything to help address this problem?
Well, the designs, or you mean the analysis of them. I would say the analyses do have an element that helps address this. Okay? So that's my response to that. But let me continue with this. What if we can, so here, okay, I just want you to dwell on that for a moment. To understand that every one of these studies could be right, and the overall summary conclusion that most observers would draw from them would be wrong. And that includes a lot of trained statisticians, a lot of professors of statistics would get this wrong, okay? Just off the top of their head. You have the extra defense, of course, of knowing something about the topic to add. If you don't have that, you reach the wrong conclusion. Okay, so here's a question. What if we increased it to 20 studies, all of them with p greater than 0.05? Okay, would we now affirm safety? Could we now affirm safety based on that evidence? So they've got this huge, vast body of literature, just like the ADA talked about, where nothing, quote unquote, nothing was found, meaning there was no statistically significant difference. Would that affirm safety? What do you think this situation would, how would it change? Does that help now that we've done more studies, more perfect studies, accumulated more non-significant results? Here you would have expected under the null at least one significant study, a statistically significant study. Any ideas? Well, you know it's a trick question, so you're not answering, right? Okay, well, here's the answer. No, even more emphatically. Now, suppose we've got 20 p-values, all 0.10. Again, I'm just using that for simplicity. But you can make up all where they're all over the place, and the same kind of thing happens. They're all greater than 0.05. Here, the Fisher summary p-value would be 0.0001. How many asterisks would that get? In other words, we could have, this problem only gets worse as the amount of evidence, the number of studies, these perfect studies, increases. This is how paradoxical real statistics is. Okay? It's utterly paradoxical. It's so paradoxical that you could go and get a PhD in statistics, become a professor, become famous in your specialty for doing whatever it is you do, and you could miss this. Why? I've seen it happen. I've given you an example, simple examples. This is much more subtle than the one I gave you, the example I gave you with Gibbons and Neurontin. Okay? Nobody's ever gotten this right, including in stat audiences I've given this. Okay? So don't.
Does this assume that it's impossible to prove safety?
No, it doesn't. It's just that you have to understand. Well, yes, it is impossible to prove safety. It's impossible to prove safety if you start with a completely agnostic position and you take say something like a falsification is refutationist view, that you can't prove hypotheses. You can't prove. All you could do is get closer and closer to saying whatever harm there is, it's so small it's beyond our detection threshold. And that may be good enough. In fact, it often is. Okay? But I want you to appreciate the paradoxical nature of this. This is an example with a count of 0 of the fallacy of vote counting, using the number of significant studies out of the total. Now, more often I see literature where, say there are 20 studies, and they have their imperfections, of course, and some of them are significant. They'll say maybe 4 of them, or something like that. And they'll say, but in the totality, most studies found nothing. That's how they're reported. The vast majority of studies, 80%, whatever it is, found nothing. Even if they all found nothing, they could still, when combined, be screaming loud and clear, there's something there. Now, here's one way you could appreciate it, by extremes, logical extremes. Imagine that every study was of sample size 2. One treated this way, one treated that way. Okay? Now how could any of these studies show a significant outcome? No, not one of them would even have a chance. They'd have 0 power, one way to think about it. Yet, you could break up every study, every set of data, any body of evidence you wanted. You could break it up finely enough so that nothing was significant anywhere. Only when you combine them would you get statistical significance. That's a problem with the methodology, the techniques, however you want. But it's not a problem in a strict logical sense. It's a problem in a psychological sense. It's hard to get your mind around. This is almost like a amoeba strip or a Klein bottle or something like that. It's hard to see. How could that be?
Senator, why did Fisher say that if you get a low p-value, then you should take note of it and do the experiment over again? That's what he said.
Why did he say that? Well, he wasn't thinking in these terms. He was saying he doesn't trust single experiments to make any kind of decision. Well, that's smart. I mean, he was very smart, and he said, with any of these people, I can read most of what he says and say, boy, that's eminently sensible. It's just that it's interesting to see how people, in the smartest ones, and nobody questions that he was a super genius, when they go off the rails, they can go off the rail big time, like with the smoking and lung cancer. And what is it? It's the eminence effect. The more puffed up they are, the more they are not going to even question themselves and become walled off to accepting the fact that they could have actually stepped off a cliff in one direction. But anybody and everybody can do it. There's one way of putting it that's a little too blunt for some people's taste, but I think I never get any objection from psychologists when I talk about this. It's that people are stupid. Everybody's stupid. Einstein was stupid. Fisher was stupid. Newton was stupid. I'm stupid. You're stupid. We're all stupid. This edifice that we have here, this was created by many, 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 many minds coming together, interacting and so forth. It's an edifice. None of us could have constructed on our own. Fisher didn't construct his thing on his own. There's some book or discussion I saw where they were talking about how Fisher invented significance and all this and blah, blah. He didn't invent it. You can go back to, at the time he was just coming up, there were articles in the literature complaining about misinterpretation of statistical significance, that it's not the same as subject matter, clinical significance and so forth. So it wasn't something he came out with on his own. This is a massive edifice, and when we tend to think, oh, it's one mind that produced this. This is a product of a collective, all of this. And we all are, and how we think, and all this structure. And it's produced things that are beyond ordinary ability to grasp. So you have to be so careful in dealing with these issues. Now, so if we take this, as is often done, if p greater than 0.05 is sufficient to write no link was found in a comparison, what sample size is required to report such a conclusion? And the answer is sample size of 2. Note that for a binary outcome with 2 subjects, one in one group, one in the other, that p1 can't be less than 0.25. And the two-tailed p-value can't be less than, it has to be 0.5, okay? So power is 0 and safety is assured. As we all like to say in my business, if you want to prove safety by the standards being applied, for example, we see in courts and hearings and so forth, some of the drug companies and especially their lawyers want to apply. If you want to prove safety, all you have to do is conduct a trial of 2 people, and you will prove safety. You'll get p greater than 0.05. Now, this kind of failure to summarize evidence or other more subtle kinds, that's actually the more obvious. The failure to summarize evidence properly is routine. It's usually innocent, but not always. It's become what I just showed you has become part of the divide and conquer strategy, we call it, for product defense. It stratifies by age, sex, eliminating significance until one can say, no link was found by this study. So you can have the study, it's done really well, everything's done well. Well, one thing that peculiar you'll see is that they don't do combined analyses. They have an analysis for men, an analysis for women, analysis also by different age groups, because we know it can't be the same effect in this age group and that age group. You follow that strategy, you're guaranteed to get the phenomena eventually you want, or maybe you'll get one significant, but it's a subgroup analysis and it wasn't, so it's just chance and on and on and on. You can prove safety if you know how to do it with any data. Okay. The key difference is that most everyone warns against and decries data dredging. And when you do data dredging, your alpha error, by the way things are set up, is limited to 5%. That was the purpose of it, of null hypothesis testing. But almost no one warns against power loss from subgrouping, for which the beta error, the error of missing a true effect, can approach 100%. There is no bound on how much beta error you can get, even though there's a bound on your alpha error. A very low bound, 5%, whereas beta error can just go right through to its roof. Now, then you might the danger is I just told you that, and you might say, oh, well, then the big thing to look for is to see whether they did a power analysis, whether the power was adequate and so forth. That's the natural response to what I just said. I do believe. I've seen it, right? Wrong. It's the wrong thing to do. Here's the problem with it. So some say the problems of null misinterpretation arise from underpowered studies. Okay? But if we have well-powered negative studies, we can be assured that the null is supported by non-significance. I call this a half-truth of the worst sort. Power is good to design into a study. That's what it's for. And it will result in more precision, as reflected by narrower confidence intervals. But it can be a disaster for interpreting studies, amplifying the misinterpretation of non-significance. Okay? So it's sort of, it gets worse going from the previous example. Post hoc power is even more counterintuitive to interpret correctly than our alpha levels and p-values. And I just showed you an example of how counterintuitive p-value analysis can be. Okay? Power only refers to future studies or some historical future before the current study was done. It has no value for interpreting data in this sense. That power provides no valid inference beyond p-values and confidence limits. And this has been written about Cox in 1958, Goodman in Berlin, 1994, and it's in Modern Epidemiology with a bunch of other sites too. Non-significance plus high power does not provide evidence favoring the null. So this is most important because I see this all the time now. They say, we got non-significant studies. It was a highly powered study for the outcome. We have shown safety. Okay? Sound plausible? Sounds reasonable? It flies? It's wrong. Here's an example. High post hoc power, null p-value greater than 0.05. And this here I'm using a two-tailed p-value. Just suppose we've got a perfect randomized controlled trial. Just these numbers are simple so that you could put them through yourself by hand on a calculator if you wanted. P greater than 0.05 for RR equals 1, the null. So it's negative by statistical significance, usual standards. And the power for doubling of the risk, which is the usual alternative bandied about in a lot of the cases I'm in, is 80%, over 80% at the 0.05 alpha level. Okay? Here's a question. Here are two questions. Does this favor our relative risk of 1 over a doubling of risk? Does this favor no effect over a doubling of risk? Okay. So that's the first question I want to ask. Roger,
I have to calculate it, but the p-value could be the same with each of those nulls.
Okay. What is the p-value for RR equals 2? Okay. So you can see this data. By the way, you can look and see what the RR is in this study right away. 48 over 32, it's 1.5, right? Arithmetically halfway between, geometrically actually closer to 2. Let's look at it. The p-value for R equals 1 is 0.07. The p-value for a doubling is 0.21. We can look at it other ways. The likelihood ratio comparing a doubling to no effect is 2.3. The estimate, we can look at the confidence interval. It goes from 0.96 all the way up to 2.35. This being a perfect study, we could say, this is quite compatible with anything up to more than a doubling. So despite non-significance and high power, that's the usual standard these days for adequate powers, 80%. All the results, every statistical method for comparing the two favor a doubling of risk over the null, no effect. So this is how misleading that kind of statement can be. Only by looking at the original source data, the original results from these studies, could you determine that this is what was going on, or not, okay? You cannot get out of these straight statements that you get all the time, and as I said, in all these contexts, in articles, editorials, reviews, hearings, etc., hearing proceedings, testimony, public record, you couldn't get this. People are using the kind of fallacious argument all the time. It's claiming that this shows safety. It does nothing of the sort. Now, after all that, how do the ADA and FDA statements hold up in light of pediatric trial evidence regarding amalgams versus composite? Okay? Let's remind ourselves, ADA said, credible scientific studies affirm the safety of dental amalgam, and they made no qualification for children under 6 or pregnant women. Whereas the FDA said, made this note, very limited to no clinical data is available regarding pregnant women and children under the age of 6, including infants who are breastfed. But then they said, of course, you should talk to your dentist, as if your dentist is going to do better than a professor of statistics in interpreting the literature. Well, let's look at the trials, okay? I presume you all know about these, or you ought to anyway, because now I do, and I don't know anything about the topic. We've got these 2 trials that were funded by large part by our national institutes. And they're, I thought, very good ideas, very good trial designs, up to 7 years follow-up in this one, De Roon and Lauterbach, these 2 reports of the same trial in Portugal. That's going to be important. In Portugal, and age 8 to 12. Okay. Now, they did find very significant, much higher mean-adjusted urinary mercury in the amalgam group. So there's no question, there's mercury getting into them, extra mercury from the amalgam, okay? But they found essentially 0 differences, all with p greater than 0.025, in measures of memory, attention, visual motor function, nerve conduction velocities. Unfortunately, they reported, here's a defect in the reporting, not the conduct of the studies, that they reported them all as z-scores, which are not validly combinable across studies. Ideally, any study should be reported in a way that makes it easy to combine with other studies to avoid some of the fallacies that I've been showing you. And they made that very hard. Nonetheless, when you look at the graphs, you can see there's no difference between the groups in any of the outcomes they looked at, both the reports. I mean, when I say that, I don't just mean non-significant. They're right bouncing around each other, okay? They did make a comment at the end about, because they also looked at the need for additional restorative treatments. That was approximately 50% higher in the composite group. That's, of course, very relevant for the trade-offs. Okay. Then the other trial, Bellinger, reported in 2 places, 5-year follow-up, about the same size, age 6 to 10 at baseline. Okay, so only one of the trials went down to age 6. It was 2 years younger. Again, they found very clear elevation in mercury, urinary mercury levels in the children who got amalgam. There's no question mercury is getting in measurable amounts. Okay, and that difference is reasonably substantial relative to the baseline levels, which are around 1. Okay, but again, they found no difference in any of the outcomes, and looked at taken as a whole. In fact, there's a very slight tendency more often for the outcomes to be a little bit better, certainly not significant enough, but a little bit better in the amalgam group. Now maybe that hints at something, a problem with the resins, as some people have mentioned. And then they didn't directly talk about the need for additional treatment, but they said there was basically no difference. It wasn't statistically significant. No difference in the need for additional treatment between the groups. But in fact, there was a little, if you looked at their results, there was this consistent favor for the amalgam group to have less need for more treatment than the resin group. Again, that wouldn't be a surprise to any of you based on the durability of the materials. Okay. What did they conclude? Well, De Roon et al. Said, these findings, combined with a trend of higher treatment need later among those receiving composite, suggest that amalgam should remain a viable option for children, but with no qualification for children under age 8, whom they didn't look at. And as the FDA points out in their discussion, there is evidence, there's a good basis at least for thinking that you get higher sensitivity as you get into lower ages. Okay. Bellinger said, although very small effects cannot be ruled out, so they're a little bit more cautious about the statistics, but they don't pay much attention to the higher treatment need in the resin group. They say these findings suggest that the health effects of amalgam restorations in children need not be the basis for treatment decisions when choosing restorative materials. But again, no qualification for children under age 6. So what they're doing is generalizing downward in age, below where they looked. Now, we could argue mechanistically and so forth about that, and you would have to get into a lot about mercury toxicology and age effects and so forth. None of that's addressed by any of the data that they're dealing with. Okay? In fact, as the FDA says, there's not much data there. So this would be a matter of pure speculation. Does this tell us safety for young children, very young children? Okay? It doesn't. Of course, these results went into the echo chamber, as I said, secondary reports and editorials, some of which were not so bad. I'm not presenting the better ones. This one jumped out at me, though, because it was so, the title was so awful. This is from Journal of Evidence-Based Dental Practice, 2010. So a few years later, this appears, discussing the results of this study demonstrate that exposure to mercury from dental amalgam does not adversely affect neurologic development in children. Once again, no qualification for children younger than observed. I think that study he was discussing was Deron, or maybe it was Bellinger, I forget which, but it doesn't matter. So here's my impression of what happened. The FDA read and thought about these studies beyond what the published reports offered. The American Dental Association, whoever wrote that page, and Mackert, did not, merely embellishing published conclusions with a patronizing spin on safety. Okay? They just said, they didn't even take the conclusions as given, suggests, and so forth. They just spun them into safety, safety, safety. The FDA did make one questionable recommendation, but they probably had no choice, recommend practicing dentists as the final scientific advisor for the patient. That's caveat emptor, right? Whatever the right phrase is. How many of you knew all the fallacies I just showed you, illustrated? I didn't just say they existed. I showed you numeric examples. How many of you knew they existed, all those existed before today? Anybody? No, I don't think so. I don't, because it's generally the case. So how many dentists are going to know it? You are all come here as endodontist specialists and coming to the scientific session voluntarily and showing up after lunch voluntarily. Practicing dentists, they went back. They're going to look back at the literature like these summaries for practicing dentists who happen to read the literature like Mackert and see stuff like this, which is spin. And not in the sense of particle physics. This ain't rocket science, but it's actually in some ways more difficult because of the interpretational issues. Data are hard to interpret. Statistics are hard to interpret. They're so hard that we humans don't seem to be able to do it. It's been documented over and over again, including all of the Kahneman, Tversky, the whole cognitive biases, that literature, that people are terrible intuitive at probability. Percy Diaconis, some of you may have heard of, MacArthur Fellow, one of the most famous probabilists of our generation, and professor, one of the few people who was awarded simultaneous professorships probability, theory of probability at Harvard and at Stanford, said that it is so hard that if he doesn't keep reminding himself all the time, when it comes down to just everyday issues and things like this, he's just going to be reminding himself of all the fallacies and pitfalls that people automatically do. He will make the mistakes. Now, if Percy Diaconis makes the mistakes, what chance do I have if I don't have constant reminders I've written on the back and front of my hand? What chance does even a dentist who's trying to keep up on the literature, reading the ADA journal, the journal of the society that put on their website what I showed you, what chance do they have? What do we have as individuals? Not much at all. I say snowball in hell. So what can we do about it? Or they don't want to. I should have had a final slide saying what we can do about it. Well, that's where we throw it open for speculation. But I would start that off by saying we have today tools to do that. And the first tool is to have the online groups that you have, the forum, where you're sharing case studies, but you can also be sharing all these, talking about all these problems when studies come out, analyzing them all together carefully, looking for all these pitfalls that you've been reminded of, saying what can we really conclude as opposed to what the authors said you could conclude. How can we delineate this carefully and admit to what we don't know? That's what I meant about delineated agnosticism. We know some things. It's not total agnosticism. We know nothing. It's delineated. We have reached some level of information, of knowledge, but it tends to be much smaller than what people think. And by having your online groups, you could do this. You could actually not just reach out to so-called fringe groups, cranks like Dr. McCullough. You could reach out perhaps to the broader community of endodontists and of dentists and the ADA and so forth to clean up these issues, and to maybe insert more honesty, like we saw at the FDA website until the very end, about these issues. Well, at the end, they were being honest in the sense that their hands are tied. I mean, I know the people in the FDA, and I know what they face politically. So I wouldn't want to be in their shoes. But you can, I believe, you can make a difference. And the online community is a tremendous tool that's only arisen within the, past decade or two, giving you the power to do that. And now everybody's online, everybody, including those dentists. Okay? So that, at that point, I would just say, throw it open to wherever you plan to go with it. Thank you.
So I think, to summarize where we are so far, the beginning of the morning, I was trying to make the point that there's many things that we wish we knew, or we think we know, or we hope to know that we just don't. That we need to get over ourselves and be honest with ourselves and our patients that we don't know the right answer in terms of what parts of treatment will affect the outcome for the patients. And I think this fits extremely well with Sandra's presentation, which is even traditional measures of evidence are biased in ways that can allow people or lead people to making very strong conclusions that are in fact just not supported by the data. So essentially, I mean, this is depressing as hell, right? We've spent about almost 6 hours. The lunch was great, and we're leaving you with like, well, what am I supposed to do with this? So what I'm going to try to do for the next period of time before we go into the Q&A, and again, you can interrupt me with questions and then be prepared for my response. What I'm going to do is try to lay out what I think you ought to do. What I think you ought to do as a specialty, knowing full well this is easy for me because I'm not going to be doing it. And most of what I do in my academic work is exactly this, giving advice on how people should try to get evidence to inform their scientific or clinical domain, and then walking away and not having to actually do the hard work of collecting the data. And it is really hard to collect good data, and I don't want to give that short shrift. So as I mentioned at the end of the part that I gave earlier, there's tremendous enthusiasm for this big data idea, the idea that we're now using electronic record systems, electronic data systems to support clinical care in a wide variety of settings. We're collecting all this data on patient characteristics and follow-up and outcomes and what treatments they got. So can't we just take all that information and use some really fancy statistical methods, because you just heard how reliable those are, and figure out what it was that made the difference? Okay? If we have enough people in the database, I can find out what's best for tooth 22 when it doesn't have a 21 or a 23 and, and the person's 52-year-old and diabetic. Okay? The problem with this is that it is it's worship of a false god. Because in routine clinical practice, there is always confounding. There are always reasons why one treatment was selected over another, whether it's patient factors, practitioner factors, geographic factors, economic factors. And so this confounding, or these correlations, or these hidden reasons why things happened the way they did will create biases or little errors whenever you try to attribute those outcomes to the differences you're interested in, like which technique was used, or was it a little hole drilled or a big hole drilled. The most dangerous thing about big data from my point of view is that it has the power to take little random biases that mean nothing, or random in the sense that you don't understand them, and convert them into highly significant p-values that look like absolute truth. So it takes things that you don't understand and makes them look like really important findings that are unrefutable. Who would argue with a p-value based on 50,000 patients that has 5 or 6 zeros before the first digit? That seems like it's a real effect. It is real information that the outcomes of patients differed. You just have no idea why. Okay? And when you don't know why they differed, it can't inform your practice. So it is more important to have data that are collected in a way that's valid, meaning the differences reflect what you want them to reflect, meaning the effect of a treatment selection, than to have data that are precise, because getting the exact answer to the wrong question is popular but does not help you. Okay. So if you search big data on the internet, you can find all kinds of cartoons. Let's solve this problem by using the big data. None of us have the slightest idea what to do with. The real problem, and I should have had something fly up and cover the caption here, is people think they know what to do with it, which has something to do with hand-waving multivariate logistic modeling or other corrections, and they just don't. So my first take-home point, I know 2 p.m. is a little late for my first take-home point, is that whenever possible and ethical, you have to do randomized trials if you want to truly understand the causal relationship between treatment selection and outcome. Now, Sander is renowned for understanding observational data. There's a lot you can learn from observational data, but in the setting of learning what's going to happen when you intervene on a patient's behalf, the observational data help you inform you about what you ought to include in your randomized trial, in my view. Okay. So what are the problems with randomized clinical trials? The first is that they are really, really, really difficult to do. They are expensive, they're time-consuming, they're frustrating. They take time, they take money, and people have an uneasy relationship with the ethical issue of randomization. I had a conversation at one of the breaks and at lunch where someone was saying, if we're doing a randomized trial, but what if I usually select one of the treatments and it's my bias that that's probably a better treatment? Well, the first is you're probably wrong. There's probably not enough information to make that decision. But the decision about what gets included in a randomized trial really needs to be a consensus. You need to use the wisdom of the larger community and believe that if the larger community believes that there's uncertainty regarding the best therapy for a group of patients, that you can communicate that. I would also argue that it may feel wrong to allow a patient's treatment to be randomized when you would normally choose one treatment over the other. But it is far more wrong to insist, through the lack of doing this, that all future patients get treatment allocated based on what that person sort of suspects is better. Okay? If we're not willing to randomize, we are condemning our patients to years of treatment selection based on ignorance or superstition or beliefs in models that you cannot prove to be true, and I suspect are highly flawed. Okay. So the first get over it yourself is get over the whole model preoccupation, because it is not helping you. And the second is get over a reluctance to randomize, because if you can't get over that as a specialty, you are stuck. Okay? So other things about randomized trials. You have to think about the population, because the result is going to give you information about the kinds of patients you included. The treatment settings, are you doing, the comments made earlier that treatment settings or outcomes in academic centers or in clinics where everybody gets treatment for free are different than in private practice settings in the US. Think about the treatments being compared, that they are all reasonable things that you would allow your patients to be used on your patients. What kinds of outcomes are important to your patients? And that clip in which I was sort of snidely making this comment about, who are we treating? Are we treating you or are we treating the patient? You just have to get over this thing that a really pretty job, you look at, I'm sure you guys have, sometimes you look at the tooth when it's done, you go, my God, I'm good. Okay? 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 You have to realize that that's a wonderful feeling, okay, completely irrelevant to the patient. Someone was saying, I don't mean to pick on anybody, but there was this comment about some technique leading to different, was it coronal leak? Yeah, coronal leak. I have no idea what this is. It sounds bad. And I'm just thinking, the patient doesn't think, oh my God, I just hope I don't have a coronal leak. Nobody thinks that way, okay, if they're not an endodontist. So we need to think about outcomes that are important to patients. You need to realize that differences in techniques in your specialty are likely to have important differences in long-term outcomes that it will be completely unapparent in short-term outcomes. So give up the 12 or 24-month follow-up. Okay, if you don't have good outcomes by then, then you should be in a different business. And there's obviously a lot to do with statistical analysis that's been covered quite well in terms of the logical fallacy. So there's a lot of hard parts here. A question that was asked of me in one of the breaks was, did I seem to be saying that I knew bacteria weren't important? And if it came across that way, I really apologize. The point I was trying to make is, I don't know. I have no idea whether or not you should scrape out every little bacterium from a canal and take out a bunch of, I guess it's dentin, do I have my anatomy right? Okay, with it. Or whether you should just reduce the bacterial load a little bit and leave a lot of dentin, because maybe that dentin is really important for long-term tooth survival and function. And I don't know, but I don't think you know either. And there's an analogy in aviation that's something like this. So airplanes are built so that the wings don't fall off very often. And even though we now learned that they can't fly. And they're stressed to be able to take a certain number of G stress before they will fail, mechanical failure. And if you know in acrobatics, planes often have 2, 3 G stress, and fighter planes maybe even 4 or 5 Gs. Okay, commercial airliners are stressed for 2 Gs. Very, very low number. And if you think about this, you think, wow, this is concerning, because you can picture scenarios where the plane will actually fall apart. So why don't we make airplane wings stronger? It's not cost, incidentally. Weight, exactly right. The only way to make wings stronger is by making them heavier. And if you make them heavier, you end up with a plane in which the wing does not fall off, but it's less maneuverable and it tends to crash more because the pilot has a harder time getting out of those very rare, difficult situations they get into. So you change the failure mode, but the net safety is not improved. I want you to think in terms of competing risks. I have no idea where the sweet spot, if you will, is between removal of bacteria, if that's helpful at all, and saving dentin, if that's helpful at all. Okay? But I have no reason to believe that you got it right by focusing mostly on bacteria. Okay? You may have, if so, it'd be luck, but I have no reason to believe it. I just don't know, so you've just got to have to figure it out by doing studies in which you actually compare these different treatment approaches. So let's talk about that a little bit. So let's suppose we were going to design a study, and I was originally going to use the implant versus endodontic treatment comparison, but I'm gathering, correct me if I'm wrong, that there's a current controversy that has to do with how aggressively you try to get all the bacteria out. What's the less aggressive technique called, the newer one?
Minimally invasive.
Okay, so minimally invasive versus traditional? Okay. Traditional, is that fair? Okay, that's what I'm going to use because I have no idea what I'm talking about. Okay. So let's consider a study where we are comparing minimally invasive versus a traditional approach, because we actually admit as a community we just don't know. Okay? And the best treatment selection may depend on patient characteristics. Maybe you should do one thing on a molar, one thing on an incisor, one thing on young people, a different thing on old people. Maybe it depends on if it's initial treatment or retreatment. There's all kinds of things that might change the selection of the optimal therapy. You realize we just don't know. So in order to address this, we'd want to enroll a patient population that can truly inform clinical practice, which means it has to be a heterogeneous population. You have to understand that you're going to have clinically important subgroups of patients who might have different needs. You're not going to write your inclusion criteria so narrow that you answer precisely a question about the best treatment for patients you will never see. Because then you'll do what we all do in clinical practice, which is say, well, I know this works really well on these people, so I'm going to use it on you. Let's let's cross our fingers. Let's not do that anymore. And then there's the question about the average treatment effect. I'm assuming that teeth that look different to a layperson might behave differently under treatment. And old mouths might work differently than young mouths, et cetera, et cetera. And people who have diabetes might be different than people without diabetes. So is the average benefit, the average advantage of one approach over another even relevant? It applies to a population on average. It may not apply to any patient you can identify. So we have to be willing to embrace this idea that there will be different answers for different people, and we're trying to figure out what's the right treatment for a different type of patient. So if the patient population is heterogeneous, you want to anticipate what we call a heterogeneity of treatment effect, which simply means what works well in one person may work less well in another, and vice versa. And we want to define our clinically important subgroups based on what we do know about how patients behave. Clearly, there's a lot of observational data which tells you which teeth are likely to do well, which are less likely to do well, what things seem to change prognosis. Things that change prognosis are candidates for things that might change the best selection of therapy. But those are very different. Prognosis is how well everybody does on average. What changes treatment selection is what is going to work best for you. So for example, one drug, I'll use morphine. It's a drug that I like to give, makes people happy. Morphine works better than Tylenol for pain from an open fracture and for headache. Sort of true. And those things have different prognoses, different levels of pain, but the treatment selection is not different. The ordering of the efficacy of the treatment approaches is the same. You can have other situations where, because the patients are different, the actual optimal best treatment is different, and that's the more important heterogeneity of treatment effect. And then internal versus external validity, you want to do your study in a way that the results from the study are valid for predicting what's going to happen in your practices when you make treatment selections based on the results of that study. And that's external validity. And most things that we worry about in clinical trial design are aimed at internal validity. Not all, but I would say numerically most. We can come back to that. Okay. So how do you pick what treatment strategies you want to compare? So could we come up with 10 or 20 hypothetical clinical scenarios with those little x-rays where you all see lucency, I don't. And could we come up with 10 or 20 where at least a quarter of you would treat it differently than the rest? Is that easy? Is that hard? Okay, easy. So you know you have uncertainty. And I would argue that if in clinical practice a quarter of the patients are likely to find a practitioner who recommends something different than the rest, your community does not know the answer, and you've sort of, by the way you think, the way you're thinking, you've admitted you don't know the answer. Now that doesn't mean that an individual within the community doesn't feel really sure that they're right, okay? But that lack of clarity across the specialty suggests you just need to bite the bullet and do the randomized trial. And you have to become comfortable with this idea that even though you might do it one way, if there's enough group uncertainty, it is ethical and appropriate and the right investment in the future of the specialty to randomize. So let me just give you a hypothetical question. You have a family member and they have a tooth that's has your disease, and they bring you an x-ray and ask what to do. How many of you feel comfortable sending them to another endodontist who is well-trained but who you don't know at all? So you just know where they went to school. How many of you feel comfortable doing that? Oh my God. So you think your entire specialty is just a crapshoot. I gave you the well-trained.
We can't see any x-rays of the work?
No.
We see x-rays of the work?
No, you have to pick them the same way I pick them. Okay? what do you think? Where's the gentleman who treated my wife? Are you still here? Okay. Okay. This gentleman was selected because the periodontist, who we really like, okay, I have a little text from my wife that says, oh, I love Dr. Yang, by the way. That's how we got this gentleman's name. I don't know anything about him. I'm actually happy to see that he's here. This is years after he treated tooth number 25 in my wife's mouth. Okay? Okay? We all who are not in the community have to make selections, and you've just basically said you think we're just all just like playing craps or roulette. Okay? So this is, by the way I feel about physicians. Okay? 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 So, okay. So the average physician in the community does not inspire confidence in me. Okay? I know a lot of very good emergency physicians. We're all in this boat. The trick is realizing that this means you have got to start being willing to realize that the investment in your specialty requires that you allow, when there's heterogeneity of opinion about treatment selection in a group, to allow you to give up your personal belief system, which I have no reason to believe that you're any smarter than he is, okay, or vice versa, and be willing to randomize so you find out which one of you might have been right or maybe you're both wrong, and not worry about what it is. So there's a PhD student I worked with a long time ago had this saying, and I don't, if anybody knows where it comes from, I'd like to know. It's the facts are friendly. Have you heard this? The idea is that let's stop worrying about what the truth is. Let's find out what the truth is and be happy that we know the truth. And if one of our preconceived notions turns out to be wrong, that's okay. If it turns out to be right, maybe that person can be a little smug for a day, get over it, and then we move on. Okay? So we have to adopt that learning mentality as opposed to these, frankly, quasi-religious arguments that are not helping you in making treatments. Okay. So when you're selecting treatments to randomize in a trial, what you should do is come up with a bunch of scenarios of common clinical problems and find out whether you have a variability in the recommendations within your community. If you have substantial variability, you ought to randomize it and find out if it makes a difference. And it's fine if it doesn't make a difference, but you ought to know that it doesn't make a difference, or at least a clinically important difference. The other reason to randomize a therapy, if there's a new technique that comes out that you think really has the potential for substantial benefit over an existing approach, that should also be required. But my impression is that you have enough practice variability within accepted techniques and when to recommend them that you have fertile ground for doing research for the next 20 years. Yes, sir?
So that quote, was it by Carl Rogers?
I don't
Facts
know.
are friendly, because the whole quote reads, the facts are always friendly, every bit of evidence one can acquire in any area leads one that much closer to what is true.
Oh, that's even a better extension of it. So whether or not that's where I got it, I like it. Okay. 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 So let's talk about efficacy research versus effectiveness research. So efficacy research is largely focused on finding a very precise effect of a very precise treatment in a very precise population. So it tends to be in a traditional research setting. It's the classical randomized clinical trial, and it's centered on a disease and a narrowly defined patient population that is often selected to be as homogeneous as possible. It's incredibly important scientifically when we're trying to demonstrate, for example, a new type of treatment has efficacy. Okay, so if I had a new treatment in sepsis or something that was intended to prevent Alzheimer's disease, these areas in which there's been virtually no progress at all, it would be completely fine to have a very narrowly focused efficacy type research study, because if I can show that I can delay the onset of Alzheimer's in this narrow group of people with this particular mutation, that's paradigm shifting and opens up a whole further areas of study that may benefit patients. In contrast, effectiveness research as a philosophy is intended to reflect the experience in a real clinical setting where there's heterogeneity of patients and practitioners. There may be a variety of disease severity. The population is much more heterogeneous. They may use quasi-experimental design, so everybody whose practices in an odd zip code has to do it this way. Everybody in an even zip code does it another way, and then we switch after a year, those sorts of things. And as a general rule, we try to use outcome measures that we know patients actually care about. So that's not coronal leakage, it's not apical lucency, it's not bacterial counts. Is my tooth look good, pain-free, can I chew, and did I not have to go back to the damn, dental professional of any sort? Okay? That's what people care about. Okay. So you want the type of outcome measure, whether it's an efficacy study or an effectiveness study, to match the philosophy of the research that you're doing. Okay. So I went through some of this a little bit last time, and I think I'm going to shortchange it a little bit because I want to get to some of the final points. But the idea here is to make sure that you focus on things that patients are aware of, not things that are sort of traditional scientific endpoints or things that just make you feel good about what you've accomplished through your technical skill. There's this concept of patient-centered outcomes research that has as a key piece of the philosophy the idea that the patients are actively involved in defining what the outcome is. And not surprisingly, a good way to find out what patients care about is to ask them. And then health services research is research in which you're interested in the configuration of the healthcare system. So for example, it's not obvious to me that people who do implant dentistry and people who do endodontics shouldn't always be in practice together. Okay? So that there's no practice bias in terms of the selection of treatment. So just throw that, I'd probably leave no one unoffended. But the idea here is if one of the reasons people end up with one treatment or another is just who they go to first, shouldn't everybody have an initial consultation with both disciplines? Okay, that would be a health services type intervention. It's a change in the configuration of healthcare that might actually lead to better patient satisfaction. Okay, remember, it's not practitioner satisfaction that we're going for, it's patient satisfaction. Okay, I'm going to skip this. Okay. So quality of life of endodontically treated versus implant treated patients, a university-based qualitative research study. Anybody seen this study? Okay, what did you think of it? You're not happy with it. Okay, its goal was not to make you happy. Okay, okay. Okay, so here's what they did. They took a relatively small number of people and who had had either implants or endodontically. Thank you, Sander. Endodontically treated teeth. And they basically asked them a couple of things. They asked them about all kinds of things about their sort of oral health and their the way their oral health was affecting their quality of life. And then they did some qualitative research where they asked people basically to talk about their dental care experience and to find out through a thematic analysis what types of things people seem to care the most about. A key idea here is, as opposed to the physician or the dentist or the endodontist deciding what we think is important, we actually ask the people we're treating what's important. Okay? This is great. I'm sorry you didn't like this. You should have liked this. You should look at it again with a more favorable eye. Okay. So looking at this, and I should have brought my glasses, it says, additionally, a quality of life survey. Thank you. This, I have to get this right. The OHIP 14. I don't know why all quality measures for outcomes always have abbreviations and a number. The number is frequently the number of items you have to ask, was used. So they're asking people these qualitative questions. So here it is. Here's the 7 questions. During the last year, how often have the following occurred? You've had some problem pronouncing words, physical pain, psychological discomfort, physical disability. You can't eat. You found you can't relax because of your teeth, mouth, or dentures, social disability, or handicap. And these are all scale on a Likert scale of 0 to 4, so presumably it's sort of roughly quantitative up to sort of 0 to 28 scale. But the idea is we're not looking at coronal leakage or lucencies on an X-ray. There's no such thing as what was the term, a quiet tooth? Is that, my teeth are all quiet, but is a quiet tooth where there just has no symptoms, is that? Okay. So there's nothing about that. How is this actually impacting your life? Okay? And the idea here is that this is what people care about. And when they come to you for treatment, they want you to do something to maximize the chance that their score is 0 for as long as possible, where none of this stuff ever happens to them because this all looks like disagreeable stuff. Okay? So we should be doing research that helps tell us what we should recommend to them to help get them to a score that's as small a number as possible for as long as possible. Okay? So I just thought it was nice that there is such an instrument. And then they look at things comparing the different approaches. Now, qualitative research is very different than what you're used to. It tends to use much smaller sample sizes, and from each subject, you're eliciting qualitative themes, things they care about, and you actually stop adding people when people seem to be saying the same thing. But you're not trying to quantify how many people are worried about one thing versus how many people are worried about something else. You're trying to find out the richness of the domain of concepts or issues or components that affect their outcomes. Okay. So this is a slide, I think I used this last time. Process is not an outcome. So please don't do anything you can to avoid continuing to publish in your literature stuff in which the goal seems to be studying the practitioner. We did this, how hard was it for do this, how often did we get this to work, how often did we successfully do that, okay? That literature is highly distracting, not because there isn't some information there, but because by the time you get to the conclusion section, it almost always has conflated the success of the practitioner in doing some technical task with the outcome of the patient, and that's a link that may or may not exist. So the idea here is that we should all care about the same things. And your literature should reflect a realization that we are in a service profession. All of us are in a service profession. And so what we should care about is the outcome for the people that we are serving, and it is not us. So the patient cares about their oral health and their function, whether it's reflected in that instrument or another instrument. The parents of children are trying to achieve the same thing for their children. You should be trying to achieve the same thing. The insurers should be most interested in paying you to do things that achieve those outcomes. Okay? And that's one of the things, I don't know if this has happened at all in dental-related professions, but in medicine, it's very, very quickly we're moving towards reimbursement structures that actually align with patient-centered outcomes. So if you do more work because there was a complication, you don't get paid for that more work because there was a complication. You actually, therefore, get more pay per unit time if you avoid complications and surgical site infections and urinary tract infections associated with catheters that didn't need to be there. So this is aligning the financial incentives with the patient-centered outcomes. That's a good thing if you are a patient, and trust us, we are all going to be patients.
I would say there's creditable evidence, at least in the dental field, that we are moving towards an insurer-based benefit, period. I don't think they give a rat's ass about whether it's a benefit to the patient. And I can give you a prime example of that, namely the number of insurers that refuse to pay for the endodontist posts when every study ever provided says that the best time to do the buildup is immediately following the endodontic procedure.
Okay.
If it benefits the insurance company, yeah, then it's evidence-based dentistry and it's good. If it benefits the patient, F you.
So my counter argument, and I've heard very similar content and tone in physician groups. And to be honest with you, I have often found, and I don't have the luxury of having the domain knowledge here to take you on the details, that to be honest with you, the insurers are just taking advantage of the lack of evidence. And the fact is, the evidence more and more has to precede the payment. Okay? When I design clinical trials now, the companies that we work with ask two questions. Is the trial likely to generate evidence that would support an approval within the FDA so the product can be legally marketed within the US? And then without taking a breath, they say, will it be able to demonstrate if the treatment is effective, a degree of effectiveness that will warrant payment by CMS? Because they know that if it just shows that it's better than nothing, but not good enough to warrant Medicare paying for it, because a lot of the private insurance are going to follow Medicare, that they're just dead. And they just take that as the burden of proof. And what you're saying suggests to me is you are being subjected to the same burden of proof, and at least from the point of view of insurers, are being found wanting. Patients are not stupid as a group of consumers. If different insurers fail to cover treatments that really affect outcome, the insurers will be forced to cover. I think your problem is more likely a lack of evidence that allows that to move forward. So that may have seemed harsh. That's because it was harsh.
Patient satisfaction is very, very important.
Yes.
I'm interested in your discounting of the hallucinacy. And can I ask you, in medicine, if there was a tumour and the patient wasn't aware of it, but it was picked up in some routine test, the patient's not aware of it, and so they presumably would be satisfied because they don't know that they have a tumour. How do you see that?
Sure. I have a great and very comfortable analogy for that, and that's prostate cancer. Okay. So, the question is essentially, patient satisfaction is important, and how do I sort of reconcile the fact that if a patient has a tumor that they are not aware of, I'm going to paraphrase a little bit, that failing to detect it and tell them about it may leave them satisfied right then, but they're going to die. Okay, and plus they're upset if you tell them about it, and how does this sort of all fit together? So my analogy with prostate cancer is as follows, right? There has been an increase in the awareness of the fact that many elderly men, when they die, if they have an autopsy, will be found to have prostate cancer on autopsy. The men weren't aware of it. It had no apparent effect or minimal effect on their quality of life. There's also evidence that some prostate cancers go on and kill people in ways that are really very unfortunate and painful. And then there seem to be some prostate cancers that don't do much. And so there's this whole question about what do you do in terms of screening for prostate cancer. So there were laws passed in California that if you saw a male patient, and I may not have this exactly right, but the gist of it is you had to offer them a rectal exam and PSA screening, because somebody related to some legislator died of prostate cancer, and this was going to solve everything. Sandra, are you an expert on this by any chance? Oh, damn. Okay. Or good. Then what happened is all kinds of men were being told, wow, your PSA is elevated. Now you need a bunch of biopsies. And then they were biopsies and told, well, one of them shows a low-grade prostate cancer. You're 55. And they were told, well, you have cancer. But the fact is, nobody had done the randomized study to show that that cancer is unlikely to do anything. That cancer is likely to be sitting there absolutely minding its own business when you die at age 90, and the cancer is just unhappy because it died with you. Okay? So the assumption or the implication, which is now you need a radical prostatectomy, which can have various side effects that are detrimental to quality of life, that work hadn't been done. We sort of had this, if you will, a disease model, and we started acting on our disease model. And then what happened is people started to question the aggressiveness of the screening and the tried to define who actually needed screening because the screening was more likely to identify a cancer that was of a type that was aggressive enough that in which removing it actually on average improved the person's life expectancy and quality of life. So I think of your lucency, I don't know how far I want to take this analogy, like a little prostate cancer. I don't think you know what it's going to do. I think, okay, so I don't want to get you guys arguing because, that's, okay, all right, because I have picked up on this, okay, so, yeah, so breast cancer.
So if the lady had breast cancer and that underwent treatment, and then there was another lump that was detected by screening, but that lady was not aware of it. You asked that lady, are you satisfied with the treatment? I'm not aware of any other cancer. Would that patient be happy then to find out that on a scan there is another lump?
So I did not mean to imply that all we care about is what makes patients happy right then. Okay, so let me try to answer it because I think we're going a little off the tangent a little bit. I always assume we need long-term outcome measures. And for you guys, you need to be thinking in terms of 5, 10, 15 years. The only way to find out what you should do about a little asymptomatic lucency is going to be to not do anything and follow that patient for 5 or 10 or 15 years, okay, and find out what fraction of them go on to need treatment, and then decide for the ones who did get treated, was their outcome better? Okay? And by the way, just because you need treatment at year 10 doesn't mean you're not better off getting treatment at year 10 rather than having a tooth that was, when you're done with them, they're dead, right? Right? They're not dead? Okay, they're pulpless. Okay.
Clarification from you that you're not saying to discount the fact that it's there. In other words, you're focusing only on the patient, whether the patient is satisfied or not.
No, I'm not. I'm talking about, I don't like the patient satisfaction, like this little questionnaire you get. Was the office clean? Was the receptionist, cheerful, well-dressed, well-groomed? I don't, whatever it is. I'm talking about whether or not, or to the degree with which your health status with treatment is of a various quality for you. Perfect, pretty good, not good, horrible, miserable, dead. Okay? And you've got to be willing to ask that over a long period of time in your specialty and realize that the goal of therapy is to increase the probability that someone is happy with their outcome. Not with your decision right then, but with their outcome. Okay? And the people who have little lucencies or breast masses who go on to require horrible treatment or have bad health outcomes are not going to tell you 10 years from now, oh, I'm totally happy that he blew that off. That's not what's going to happen. Okay, so let me just try to continue on a teeny bit with this, and I'm going to skip this. I was going to do a whole bunch of statistics stuff on this because I love this, and I'm happy to come back to it if anybody is dumb enough to ask. Okay, so second take home. Your clinical research should use primary endpoints or outcome measures that are important to patients if we intend the research to influence clinical practice. And amazingly, the best way to find out what's important to patients is to ask them. Not each individual patient, but as a group to identify what it is they hope to achieve during their therapy. Some patients may really care that they have their own natural tooth. Some patients may want to just say, I just want this taken care of so I never have to see someone again. And those could result in different treatment selections for different patients. You need long follow-up, and you need to realize that the long follow-up raises all kinds of challenges. So when you try to follow someone for a long period of time and try to contact them at 5, 10, 15 years, it is often difficult to find them. And the people who you cannot find are fundamentally different than the people you can find. Maybe you can't find them, they're not returning your calls because they had such a horrible outcome they never want to see you again. Maybe they're not returning their calls because they had a fine outcome. They don't think they need to talk to anybody in your profession. Maybe they're not being able to follow them up because they died. et cetera, et cetera. There's all kinds of possibilities. Another thing that can happen during long periods of follow-up is crossovers. So the person was allocated to a conservative approach of watchful waiting. They decided a few months later they thought you were an idiot, and they went to find someone who, damn it, was willing to do the root canal. Okay? So how do you deal with those in a clinical trial? So the first, this is shameless self-promotion, has to do with what do you do when data are missing? So the worst thing you can do is pretend that the patients who are missing are exactly like everybody else. So this is what's called missing completely at random, which basically says the missingness isn't telling you anything. That's virtually never true. So there are techniques that were discussed a little bit. This is an editorial that just came out in JAMA. The first author is Newgard, and I think it's free online to everybody. There are techniques that take all of the patients and impute or insert multiple informed guesses about what the missing data might have been. And believe it or not, that results in a more accurate estimate of the true treatment effect than if you had just eliminated from the study everybody who was lost to follow-up. Okay?
How do you know what to compute?
Oh, that's a long, long, long question. Okay.
Is there a percentage at which a study is invalid?
Well, it's a great question. So I was just looking at a manuscript in which about 7% of their data were missing. That's actually a pretty low percentage. But actually, Dr. Newgard has done some simulation studies where he took a complete data set where he knew all the answers. And then he systematically, randomly gotten rid of data and shown that with multiple imputation, which is the technique I'm talking about, you can get pretty good answers with sometimes 30 or 40 or 50% of the data missing in certain patterns. Okay, so it depends a lot on the specifics. But the point I want to make is that the first thing is to obviously have as few missing data as possible. But then when you do have missing data, you have to have an approach to handling those. And I just wanted to mention that so you're on the lookout for it. So missing data are virtually never missing completely at random, although anytime you read a paper and it says, we eliminated patients who didn't return for follow-up, okay, that should just be a red flag to you, because those are the patients who may have the most interesting outcomes. So whenever data are missing, ask yourself, why are they missing? What is the mechanism of missingness? Why are they missing? What does that tell you about the characteristics of those patients that might make them different or their teeth different than the patients who did come back? So the best way to deal with this is to not have any missing data. The second best way is this technique called multiple imputation. There's a common approach that people talk about, which is last observation carried forward. In your field, that would be equivalent to saying, well, the last time I saw him, the tooth was fine, so I'm going to assume it's fine at 25 years. Okay? It's a very, very unfortunate technique that people thought was required by the FDA, although as best I can tell, it never was. Okay. The second thing I want to talk about is the intention to treat principle. And I did talk about this last time. Greg, how many people remember what the intention to treat principle is? Okay. So at a very basic philosophical level, the reason we're going to do clinical research is to tell you what you should intend to do in the treatment of your patient. Okay? So presumably, you all have had the experience where you intend to do a particular procedure and it's technically difficult and it doesn't go the way you want, probably usually Friday at about 5 p.m. Okay? So is this true, right? Do you ever? Okay. This happens to me all the time. I intend to put this, central venous catheter in this critically ill patient, and an hour later, it's not going well. Okay? The purpose of research is to tell you what you should intend to do and therefore should recommend. It does, and it has to do so in a way that takes into account the fact that sometimes we can't always do what we intend. And that's the purpose of the intention to treat principle. And then there's a JAMA statistical short on this. The first author is Detry, D-E-T-R-Y. So what determines the efficacy of a treatment? Well, the first is your ability to actually get the treatment done. So your technical skill in doing your procedure is important. The second is the inherent, I call it chemical efficacy because we often think in terms of drugs, but it's like if everybody could do this technique perfectly, what would its actual effect on outcome be? And then the other thing that affects outcomes are these things you don't have any control about that are often patient characteristics, like their overall oral health, their comorbidities, their nutritional status, their dietary and oral health habits, those sorts of things. All of those matter, and we need to think about what that means in terms of how you interpret data when the setting, especially when you may start a patient on one treatment arm and then they go ignore your advice and go receive another treatment arm, or they fail the first treatment arm and therefore in an informed way select an alternative treatment. So the really interesting thing is that in virtually all settings there is a correlation between these underlying patient characteristics that affect outcome and compliance, and by compliance I mean their willingness to follow your instructions or your ability to perform the therapy or the treatment that you intend. It's virtually impossible that someone can come up with an exception to this correlation. So what that means is that if I randomly allocate patients to two different groups, okay, I'm going to randomize one to the minimally invasive group and one group to the traditional approach. One of these may be a technically more difficult approach. Is one of them technically more difficult? Is minimally invasive technically harder? Okay. So there's going to be more cases in the traditional approach where the endodontist feels they successfully completed the procedure than in the minimally invasive arm. Okay? Doesn't mean the minimally invasive arm will perform less well. It just means you don't feel as good about it. Remember, you're not the one being treated. Okay? So there's going to be a difference in compliance by treatment arm. And then even in a setting in which it's a double-blind study, where there's pills, there's an antidepressant, one's a sugar pill, one's a real antidepressant, almost always the two treatment arms, even when the patients have no idea what's being done to them or what the treatment is that they're receiving, have differences in compliance. So in the antidepressant case, the people who are receiving the real antidepressant may take it more religiously because, hey, I feel better. This is good. They may take it less frequently. I feel better, I don't need it anymore. They might take it more frequently when it doesn't work, or maybe the placebo more when religiously because, oh my God, I got to keep trying this because I'm really depressed. There's no way to predict it, but there's almost always differential compliance in the different treatment arms. That introduces bias in that non-compliant patients who generally are poorer prognosis, but not always, will tend to leave one treatment group more than the other. So if the poor prognosis patients leave your treatment group and you ignore them and you only analyze the ones who are left, that treatment looks better. Because if everybody who's doing badly leaves, everybody who's left does great. Does that make sense?
Will Rogers.
Yeah, it's like the Will Rogers, except instead of going to California, okay, they're just disappearing completely. Okay? The Will Rogers phenomenon. Has this been in your chat room and everybody knows it? Okay, so the saying, I do not know if this can actually be attributed to Will Rogers, is that when the Okies moved to California, it improved the IQ in both states. And I was born in Southern California. The implication is that they were dumber than the average person in Oklahoma, but a lot smarter than the average Californian. Okay, so it's a very important thing in for example, cancer detection is something called stage migration, where if you suddenly classify everybody as having a later stage of disease because you're better at picking up metastases, you make all your treatments look better because you get the same outcomes with people with more advanced disease as when you've accomplished nothing. And this is actually a big concern in understanding whether we're making progress in breast cancer. Okay. So that was definitely a digression. So the intention to treat principle. So the purpose of the intention to treat principle is to estimate the effectiveness of a treatment in actual clinical practice by properly allowing for differences in compliance. That's what we're trying to do. The definition of the intention to treat principle is that patients are considered to be members of the treatment group to which they were originally assigned, regardless of what treatment they receive, either initially or subsequently. They never move out of their original assignment, even if they get the alternative treatment. And if you do this, then when you count patients that way, so that means some people in the minimally invasive group who then, even though they're assigned to that, they skip their appointment and go to a traditionalist, they're still in the minimally invasive group when you count up the outcomes at the end of the day, which seems counterintuitive to many people. What this does is ensure that the estimate of the treatment difference that you observe in the trial accurately reflects the effect of recommending the minimally invasive over the traditional approach. Okay? So I'm going to give you an example of that because I just love this example. So the alternative is by treatment received, where you group people according to what actually happened to them. It's horrible, it's evil, it's immoral because it gives you the wrong answer. And it's what's done in every single retrospective study. So when I started this morning by just perseverating on this fact that I don't know why some patients got implants and some patients got endodontic therapy, the thing that bothered me is I have no idea why, and so I have no idea what the effect of choosing one over the other is. So here's the example. So this is these are actual clinical trial data for a study that was done for critically ill or injured children in the pre-hospital setting. So these are small children who are critically ill to the point that they're not breathing well enough to support life. And there were two general approaches that the paramedics could use, and there was uncertainty in the community. One is called bag valve mask ventilation. That's the thing you sometimes see on TV. You guys have all BVMs in your office, right? You should? Okay. So the BVM, the alternative is endotracheal intubation. You guys don't do that, right? You try to avoid it, okay. You all saw it in residency. Okay, so those are the two approaches. It's hard because paramedics don't take care of critically ill children very much, which is good. And so there's an issue of skill level, maintaining skills, training, equipment, et cetera, and we didn't know what was better. So what I've done to make this clearer is I've picked two subgroups out of a much larger study. The overall sample size was closer to 1,000. But there's 200 critically ill children, and 83 are randomized to bag valve mask ventilation and 116 to endotracheal intubation. It will bother Sandra that those are pretty different numbers. We think there was some leakage out of the BVM group. And it just turns out that I've picked subgroups with sudden infant death syndrome, which is a horrible illness, and with closed head injury, but closed head injury is so severe that they weren't breathing very well. Okay. And then we just asked the question, what treatment did they receive? So if you're to the left side, where you're one of the 83 children that were randomized to bag valve mask ventilation, you should have just been bagged, because that's what you were randomized to. But for the 58 with SIDS, 2 of them were intubated, because that's a protocol violation. The paramedics so believed it was helpful that they just decided to do what they wanted to do. Okay? That's a crossover. That's like your patient who's assigned to minimally invasive and leaves and says, I'm going to find someone who's actually going to do what I need. Okay? And they all died because SIDS is a horrible disease. Of the 25 with closed head injury, 1 of them was intubated. That's a protocol violation. Of that entire 25, 8 out of the 25 lived. Closed head injury is a less serious but still horrible disease. Of the 116 randomized endotracheal intubation, there were 80 with SIDS. About half are intubated. There's a bunch that are not intubated, frankly, because the scene at the house is so chaotic that the paramedics have trouble controlling the scene and taking care of the child, and often they feel they just have to get to the hospital as quickly as possible. And of the 36 with closed head injury, 9 of them lived, 9 of them were intubated, 1 of them both lived and was intubated. So those are the actual data. So the first question is there any question about the data, about what the data, just counting? Okay, so now what we're going to do is we're going to just count outcomes by treatment received and by the intention to treat principle. So if you do this by the intention to treat principle, of the 116 on the right who were randomized to endotracheal intubation, just look at the bottom row, 9 lived. Okay? Of the 83 randomized to BVM, 8 lived. So if you look at this, the survival in the endotracheal intubation group and BVM group are very similar. So if I was predisposed to the null hypothesis, which I'm now warned against being, I would say it looks like they're about the same. Okay, it's a lack of evidence of difference. That seems pretty boring. But watch what happens if I do it by treatment received like I would in any retrospective study. The patients who are intubated are the 1 in the bottom right-hand corner, the 39, and the 8 that did not live, the 39, the 1, and the 2. And those that were BVM, even when they were assigned to endotracheal intubation, are in the left-hand column. So it's 56, 16 plus 8, 41, and 19.8. Do you see how I'm counting squares? Okay. So trust me, I've counted properly. And now when I do the proportions, the survival of patients who were actually intubated is 2%. And the survival in the BVM group, the people who were actually received BVM no matter what they were randomized, is 16%. Now it's clear that endotracheal intubation is a lethal intervention and should be banned from medical practice. So there's a couple of things that should bother you about this. One, that by this distinction I get completely different answers. This is similar to the kind of example that Sander gave, where he takes a whole bunch of non-significant studies and combines the evidence, and suddenly it's highly significant. So it's not just a little tweaking. This is changing a positive to a negative result and vice versa. Okay, this should really bother you. So if you ever count patients according to the treatment they actually receive, you will get a biased estimate of the effect of intending to give a treatment that in fact can give you completely the wrong answer in terms of what you recommend. Now, the reason this happens is because if you go back to the previous slide, you'll see that the kids with SIDS in the endotracheal intubation group, about half of them are intubated, 39 versus 41. Unfortunately, and I'm sorry about the morbidity of the example, kids with SIDS are limp. They're very easy to intubate. The kids with closed head injury still have a lot of tone, and so they're very hard to intubate, so they are less compliant but have much better prognosis. So when you do it by treatment received, the good prognosis kids that are hard to intubate get shifted from endotracheal intubation group into the BVM group because you couldn't actually intubate them, and now they bring up the survival in the endotracheal intubation group, and removing them, this is the Will Rogers phenomenon, lower the survival in the ET group. Okay? It's not a real effect. It's not the effect of choosing to intubate them. It's a complete artifact of forgetting that the purpose of medical research is to inform the choice of therapy, not whether you can actually do it. Okay, so we can talk more about that in the question and answer if it comes up. But this is why you're going to have to randomize, and you're going to have to keep patients in the group to which they are randomized, no matter what happens to them over 5, 10, or 15 years, and you just have to live with it. Okay, so the third take-home point: complete follow-up and data collection. You need to have a pre-specified and proper approach to your analysis strategy, and then the statistical methods, and all of these are critically important. If at the end of the day, you want to be able to look at the difference you observe in your randomized trial and believe that it actually tells you what the effect, the causal effect, is of recommending one therapy over another in terms of the outcome.
Thank you for having me. I'm Sander Greenland. It's an honor to be here. I'm not sure if it's appropriate because until this year, when Gary invited me, I think I was fuzzy on the difference between an endoscopy and I mean, I don't really, I realize now there are different ends of the spectrum, but I don't really, that's how much I know about your specialty. Presumably, you'll benefit by learning a bit about my specialty for your work, which has been very much focused in issues of drug and device evaluation, but not dental. I've never been involved that I can recall in a dental study. I've been involved in more and more in controversial areas of safety assurance and risk assessment. Electromagnetic fields in childhood leukemia is an example of a topic area I got magnetically drawn into, sucked into, and other controversial policy-related areas that get very ugly compared to probably some of the worst cases you've seen. But this problem is that I've been specializing in, which I'm calling safety assurance, is something that everybody wants the assurance of safety, and that's what you're trying to do with what I've seen so far. And yet, it's very, very hard to do that for reasons that have been, I'd say, understood for a good century on a philosophical level, but don't seem to have filtered into practice, the practice of research and statistics, not very effectively. Now, there are occasions in which we could provide approximate safety assurance. If the available evidence is, in some sense, shows that harms are probably small, if there are any harms. And I'm going to assume that because you're here in the scientific session, and also because I've been completely biased by the interactions I had before the conference by interacting with Dr. Kademi and Gary Carr, and so forth, that you have some background, you've already had some background in the issues, some issues, statistics, basic statistics and research and so forth. And I'm used to lecturing and to heavily statistical audiences. So I apologize if this is over your, or beyond your technical level here, and I apologize if I undershoot. I probably can't hit it just right. But I have to say that some of these slides that I'll be showing you have been well received as far, at least for entertainment value, in some quarters. So blame Gary if there's a problem on your end. Because I saw that there were these speaker ratings, and I would say, I didn't see any there for saying they were all excellent and so forth, and down to poor. But there wasn't anything there for eccentric or irrelevant or just weird or boring. But this is how for better or worse, this is how I think of things, because I'm a generalist, a methodologist, statistician. My background is very abstract. And I deal with people who will, believe it or not, will only understand what I'm talking about if I approach it very abstractly, because they are not clinicians. They are not mostly clinical practitioners. They have no background in that. They are generalists themselves, statisticians being a key example, but a lot of epidemiologists graduate that way. They have no background. When I first entered epidemiology, most everybody had a clinical background. I was among the early exceptions. But now it's heavily dominated by people who have no clinical experience or expertise or anything. They know even less sometimes than I do about the clinical setting that we're studying. And that's saying a lot. So there's various ways statistically operationalizing this idea about what's a probably small effect. Okay, but there's a technicality. I'm going to just gloss over this slide for you. So a lot of these slides I will, because these points would really be emphasized for statisticians. The statistical solutions have their own problems. Statistics is great for giving very precise answers, very precise, logically precise answers to the wrong questions, or giving very precise answers that depend on assumptions that are so arbitrary that if you understood what the assumptions they're making are, you would say, wait a minute, what has this got to do with our setting? And therefore, what does the answer have to do with our setting? So the problem with one problem with deductive logic is that it only gives you correct answers if all its assumptions are correct. And the reliability of its answers declines as your certainty about the assumptions decline. And the problem is that most of the assumptions that go into statistical methods are very uncertain in practice, and statistics in general has not adapted to the idea of how, very successfully, even though it's supposed to address this issue, it has not adapted to the idea of how uncertainty at the start of your deductions transmits to uncertainty at the end. There's one reason for that is because if you look at the real uncertainty in a lot of applied settings, it's going to end up that deduction doesn't help whittle it down very much unless you do an incredible amount of background work, which nobody has time for in the context of doing real analyses or even meta-analyses often. And often, this is what I find, rarely do data support even proximate safety assurances. And worse, rarely do summaries admit that fact. It's hard to find studies without reporting problems. It's even harder to find reviews without problems, and even harder to find professional summaries without problems. And it's even harder, gets well nigh impossible to find popular summaries, like in the popular press, or even Scientific American, so-called scientific publications, without problems, big problems. And one way you can think of this is think of the game of telephone, that the message degrades with each transmission, sometimes in a consistent direction based on prevalent misconceptions and wishes. And in fact, it starts out degraded. You could say that the data have information, they have a message, and what I'm going to focus on is how, especially here, is how that message gets degraded in step one in going from the data themselves through the statistics to the researchers and writing that report. That's step one of degradation. But I'll also mention a bit about the degradation, or give you an example how it degrades as it eventually filters down to professional recommendations, and which eventually gets to the public in an even more degraded form. And here is a key problem I have to deal with. I call it the ergonomic problem of statistics. It's something that Kahneman, who you were showing a clip of before, would appreciate very well. That proper interpretation of statistics is too complex to leave to one specialist. Whether that specialist is unfamiliar with the underlying statistics, that's a typical clinician, even if the clinician's a researcher. We don't find that they have very good understanding of statistics, even if they've had a couple of courses in it. Or if that person is unfamiliar with the underlying physical material, like a statistician. I deal with that constantly. Some of the finest theoretical statisticians, mathematical statisticians, working in a real example in their paper, and I'd say this is not what a clinician would want to see. You're presenting these kinds of results, but that's not addressing the clinical question. What it comes down to, I have to conclude, is that there has to be a group process to deal with this. There is now far too much information to expect even a very bright, well-trained clinical or academic doctorate to understand the whole situation from start to finish. You're working as a team. You have to engage, hopefully not in group think, but in group thinking, where you're critically examining each other's impressions and giving feedback to each other. You have to have the entire team check reports, I mean like research reports, and each other for cognitive biases, which I hope that phrase is something you've seen before, such as confirmation bias and other sources of overconfidence, such as multiple counting of evidence. And examine interval estimates, not just p-values. One thing about examining reports, including ones in this situation that were sent to me, is that sometimes you just see a p-value given, or maybe a point estimate and a p-value, and that doesn't give you a very good sense of what kind of uncertainty is warranted. This is a complaint that's been made for decades. The uncertainty warranted for each study. And when you do that, you can contrast what you see if you understand statistics against what the authors are claiming to have found. Now, Roger gave me an excellent introduction in that he covered the topic areas I've worked heavily in, how the reports aren't really reliable. They're not even randomized trials. What I'm going to do in the course of this is focus on what goes wrong, even if every study was a perfect randomized trial. Even if every study was a perfect randomized trial, I would bet you that we would still find ourselves with lots of big problems because of the difficulty that humans have in interpreting data, even from perfect studies, okay? And the human tendencies, okay? One of the most important elements of statistics, which seems to get left out somehow, or it looks as if it's left out of the training, is it's important to write out what the statistics mean in contextual terms. That would be in the context, in literally endodontic terms, in your terms, whatever the field you're working in. Even more important is to have, well, not even more important, I mean as important, is to have proper meta-analytic contrast and summary estimates, as well as p-values from multiple studies. One of the big problems is that even if you had a whole literature full of perfect randomized trials, the way people approach them typically will lead to bad conclusions because people will give casual impressions, eminent or authoritative impressions, vote counting, appeals to authority, and seductive mechanistic arguments, which again was echoed in Roger's talk. And in the absence of genuinely strong evidence, you have to adopt an agnostic and not skeptical response to challenges to conventional wisdom, especially regarding safety concerns. This came up in the course of our preliminary emails before I came here, that involving a website, Mercola.com, reputedly the most popular health website in the world, and certainly one of the most popular. And I follow it avidly because I want to know what's going on in that world. This is a parallel universe. It is a parallel universe where you are not trusted if you are part of the establishment, okay? So how do you build, the question for me is not how do you isolate them, it's how do you build a bridge for communication. Think of it as like the Cold War. The Cold War, which, well, at least a good portion of you would remember vividly, luckily didn't become the world's first nuclear war, all nuclear war, because instead, at some point, it almost did become a nuclear war, but they built a bridge for communication to at least avert an all-out nuclear holocaust. The same thing, I think, applies to any profession dealing with this situation. And believe it or not, I think that they have a lot of legitimate gripes. If I look at what Mercola, for example, is saying, I can see how the trust was lost, both by what is done conventionally and by the reactions that are given to what are admittedly, to me even, some of the crazy ideas that are there, okay? So, and one of the elements that I think is driving this, not that I would try and approach it this way, but the task that will confront a serious cultural bias affecting most of the statistics and scientific community. By that I mean the established community, which I am a part of, maybe some would say on the fringe. I call it nullism. I'm going to talk at length about that given the time anyway. Let's look at, to take as an example, current American Dental Association mouthhealthy.org statement regarding silver-colored fillings, right from the start. And you can find this in the Mercola website. You know, what's the big thing? They were raging against mercury amalgam, telling people to get them safely removed and put, and there is an emphasis there on safe removal. You know, he's not a stupid guy. But right there, there's a complaint right there. Silver-colored filling. That's a euphemism. They're half mercury, right? Am I right? They're half mercury, and mercury is famous for making people as mad as a hatter. Okay? So right there, they're starting to sense, it's a sense, that they're being gamed. They're being tricked. What was it that you were talking about? When people they present things correctly, but they're stating it in ways to make you misunderstand. A sales pitch, right? Right off the bat, the topic, the heading for this on the ADA website is silver-colored fillings. Why did they not say mercury amalgam fillings? Okay? I have been involved in a mercury controversy, not through fillings, but through a far more charged and a just utterly nasty topic area, vaccines. I have the bag here to prove it from a Robert F. Kennedy funded event. Go mercury free. That's with vaccines. Of course, here, what did I get? I got another bag to go with it. Mercury, a company. Was that a good choice for a name? What? I don't get it there. What universe are they operating in? Let's look at this statement. Although dental amalgam is safe, I'm going to put that in red. Whenever you see the word safe or harmful, but I'm going to focus on safe. You say, how is safe? How do you know that? Always ask, how do they know this? Commonly used dental material, right? You may wonder about its mercury content. Really? It's important to know that when combined with other metals, it's a safe, stable material. There's that safe again. Be assured that credible scientific studies affirm the safety of dental amalgam. Then they start, what does this mean? Is this scientific? The American Dental Association, CDC, FDA, all agree, they all agree, based on extensive scientific evidence, dental amalgam is a safe and effective cavity-filling material. The Alzheimer's Association, and on and on and on, also say amalgam poses no health risk. Do they say it poses no health risk? The Mayo Clinic, let's throw in another authority. Okay, what is this? This is eminence-based, safety assurance. We've got all these eminent authorities. What if they're all relying on two studies? They're all relying on the same studies, so it becomes an echo chamber. Oh, the chorus agrees, it's all safe, it's all safe, it's all safe. And it all comes down to what, one study, two studies that you could rely on without any of the problems that Roger was talking about coming into mind? So this is something to be aware. Right away, though, I think anybody reading this who ever went out and bought a car from a car dealer would read this and say, what are they trying to hide with all this? And that is exactly what I see in Mercola website. It's just like, this is immediately, sure, this will bring in, maybe assure certain people, a certain segment of the public, but there's another segment of the public, paranoid, suspicious, and willingly trying to think critically about it and say, wait a minute, what are they trying to hide? Well, let's see what one of their authorities that they cite, I've consulted for all the CDC, FDA, WHO, just got off consulting WHO about flu vaccines. Here's from the FDA website. Let's contrast it with what the ADA said. Okay, the weight of credible scientific evidence reviewed by the FDA does not establish an association. I've noticed here, and I know why, they are being really careful in their wording. Do I see safe here the way it was safe in the ADA side? I'm looking for it. Do you see it? I didn't see it. They say, does not establish an association. It's a bit more sophisticated, I'd say. Okay. Clinical studies in adults and children ages 6 and above have found no link. They have found no link. No, okay. They didn't say they've proven it's safe. Okay. Then they go on to say fetuses and young children may be more sensitive to neurotoxic effects of mercury vapor. Very limited to no clinical data is available regarding long-term health outcomes in pregnant women and their developing fetuses and children under the age 6, including infants who are breastfed. Okay. Contrast that. My question is, and given that anybody, including Mercola and all the people who read his website, can go to the FDA website and see the same thing and contrast it to the ADA website. What do you think that does for their trust of your reassurances that mercury amalgam fillings are safe? What do you think that does? Okay. I guarantee you it does not reinforce their confidence in your unbiasedness in regard to the advice you give. Now notice at the end here, the FDA says that pregnant women and parents with children under 6 who are concerned about the absence of clinical data should talk to their dentist. The FDA is punting here. I no doubt they had to do it. And then they go on to even note, some individuals have an allergy or sensitivity to mercury. This is actually one of the themes in, as some of you may have heard, RFK Jr., the stuff he has backed about people who are mercury sensitive. If you are allergic to any metals, you should not get amalgam fillings. Then they go on to talk about, they give more details, but they do give more details. So now I'm going to I'll come back to the data that focus on the pediatric amalgam trials at the very end if we get there. But I'm going to have this is my main talk here, is the general problem that I'm trying to deal with, is facing human nature and cognitive bias in science. Whenever ostensibly scientific parties offer opinions like those quoted above, we have to ask, whatever happened to scientific modesty and militant agnosticism, the kind that Huxley talked about? I'm not talking about wishy-washy stuff. I'm talking about saying this something specific that people seem allergic to. The higher they get in authority, the more they're allergic to saying, I don't know. And you don't know either. You don't know either. We don't have the data to know these things in any sense that it would be called scientifically sound by somebody who studies these matters. Okay? Instead, health scientists and professional organizations often mirror politicians for whom certainty is founded on ambiguous evidence. Okay? This is what I see in the ADA website, and I do believe others see it, including Mercola. Despite demands for absolute safety assurance, that kind of assurance is impossible according to modern philosophy of science and its statistical operationalizations. There's an idea here that people want assurances of absolute safety, so we'll give it to them. We'll say, like on the ADA website, safe, 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 okay? And yet, that's unscientific, and I mean that in a narrow technical sense, academic sense of unscientific, not in some broad rhetorical sense, but in the sense that you can go Karl Popper, falsificationism, and so forth. Safety is a very specific hypothesis. And what was it that was supposed to be the message, actually dating back to Russell 100 years ago, about the scientific method? What can it not do? What was that discovery a century or so ago, 80 years ago? It finally became popularized in journals, starting in my time in the 1970s and 80s, all these things, philosophy of Karl Popper. What is it that it can't do? It can't prove hypotheses. It cannot prove things about it. It can falsify them. It can leave them standing so that you can make use of them until falsifying data comes along. But it can never prove them. In fact, it's one of the reasons why when you read physics, discussions of physics by informed people, they talk about quantum theory, relativity theory. It's still called a theory. Even though with quantum theory, nothing has had more accurate predictions in the history of science. 18-digit accuracy in some cases. Do you get that in endodontic practice? I've never seen it in any medical field. They still call it a theory, and they still look for possible defects. Okay? So, what do we have at the ADA website? It's totally unscientific. Why are we making fun of Dr. Mercola when I can go, and he can go to anybody can go to the ADA website and even just contrast it to the FDA website and realize they're not any more scientific. They're just taking an established view, an established dogma, and promoting it instead of a contrarian fringe or whatever you want to call it, crank dogma. Okay? It's just, they happen to be in the dominant religious sect at that point. So, it's also, this is but the interesting thing about this to me as somebody who studies statistical foundations, is that this view of science is actually formalized into what has become the standard of care for study analysis since the mid-20th century, namely Neyman-Pearson, technically called Neyman-Pearson hypothesis testing, which in some sort of often bastardized form gets promoted as significance testing, statistical testing, and so forth. If you knew exactly what it was saying, if you went back and read Neyman and Pearson's original papers, Neyman's papers subsequently, which I did and had to, I was among the cohort of the last students taking his class on his research project and so forth, you know that this is exactly the philosophy that was driving him, that you could never prove anything. You could only disprove it. You could only leave it standing within the current margins of error so that it might still be viewed as useful. And that got lost somewhere along the way in basic teaching and even advanced statistics teaching. We never accept anything as true, only as unrefuted so far, and that includes safety. Okay? That means when a patient asks, is this safe? The strongest scientific answer is, so far, no one has shown it harmful, as in, maybe we'll find out otherwise with you. The question, this is one for the psychologists and so forth, I can't answer it. Obviously, I have opinions, but they're ignorant opinions. I'm not being a clinician especially, how could I have an informed opinion, is what works best for dealing with in this environment that we have, like when we have Mercola website and so forth, and the alternative dental practitioners to deal with and so forth, that you have to deal with. Is honesty the best policy? It's certainly a scientific ideal, and one I think deserves to be adhered to until shown otherwise. Oh my goodness, what's happening with these slides? Okay. Assurance is complicated by all sorts of disputes and misunderstandings about what constitutes refutation. When do we have evidence of non-safety? These problems can be mitigated somewhat by teaching that all choices involve risk-benefit trade-offs. And this is very relevant for this particular controversy about mercury. If we talk about risk-benefit trade-offs, like in the vaccine situation, we can say, get your kid MMR vaccinations. The benefits far outweigh the risks, at least we understand them currently. Or the risk we expect from harm from failure to vaccinate is far larger than the risk we expect from MMR vaccination. That's really the honest statement. There's nothing is risk-free. Part of the problem could be said, be again a cultural one. People are raised with the idea that somehow things can be risk-free, just like that ADA website makes it sound. Safe, 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 safe. That doesn't really exist in most medical choices. In fact, I can't think of any medical treatment. I was involved in studying medical device where there were not risks associated with it. It's always a risk-benefit trade-off. And somehow, can we make the public, can we make our practitioners, frontline practitioners, can we make all of ourselves much more aware that this is the real question, as it is with this situation I'm discussing, mercury amalgam versus what's the alternative? Resin composite. You can't just leave it untreated, which is not risk-free. The alternatives are not risk-free. By the way, in this comment here, as I said, I've been involved in this. For a healthy person, that benefit, that risk cannot be said with any assurance about typical flu vaccines, whose effectiveness is so low, some cases, pediatric immunization, for example, in the teens of %, some of the vaccines. It's so low that you can't even get close to herd immunity. One of the arguments that people use to try and push it is, well, you're helping everybody else by creating herd immunity. You can't create herd immunity for most of the flu vaccination situations. And there are people in WHO programs who know this very well, and they are not pleased with some of the overpromotion. Okay? But that's a side point. The lack of decisive data has led to what I call an epidemic of treating studies as if decisive. So one of my colleagues called spinning knowledge out of ignorance to conform to what is desired, which has been called wish bias. And this problem has been aided by rampant misinterpretation of failure to reject the null, which in this case is safety, that's the null, as confirmation, which is something very different from failure to reject. These failures are then referred to as extensive evidence, and their credibility reinforced by multiple attestation and misquotes of authorities. You saw all the quotes of authorities there, including what is essentially, that ADA website was essentially misquoting the FDA. It amounts to more than that. They didn't put in any of the cautions that the FDA had in their website. They just quoted them as if you go to the FDA website, you don't even have to go there because you'll see exactly what we told you. But except you don't, okay? Again, that will help erode the already eroding trust, okay? The problem is illustrated in the controversy surrounding thimerosal and vaccines and the mercury amalgam literature. And the problem would exist even if the data were perfect. So Roger talked about problems of having like observational studies, which is what I've been involved with. But problems I'm talking about would arise, again, even with perfect studies. And a major source of that problem is statistics itself. Careful reviews of original source data reveal a general problem, statistical inference, that from its original noble purpose in guiding design and restraining inference, statistical testing is degenerated into a methodology for concocting unwarranted inferences from weak data. Negative reports fished from non-significance is the one that everybody wrings their hands about. It's become just a massive discussion point, talking point, since a famous article, one of the most famous articles right now in medicine, it was in ITIS 2005, in PLOS 1. I'm sure, well, I hope most of you have heard of that. My most published research findings are false. It was an article, when it came out, and I saw the title, I just shrugged, and all my colleagues did say, well, sure, we all know that. Most research findings are false. What the problem was that all it was going on about was basically false positives. It didn't talk about the fact that often positive reports fish from significance. It didn't talk about negative reports fish from non-significance. That was the problem. And either of these processes inflates the pool of false knowledge and contributes to biased risk assessments. It's statistics that has become a major source of invalid theoretical arguments used to spin ignorance into knowledge that there's no effect. Okay, and when I say ignorance, lack of reliable knowledge about either mechanisms or population patterns. And this is a false negative bias, and it's largely overlooked by the current reproducibility crisis literature. All that literature I've seen is all about false positives. And that is important in a lot of situations. I mean, in genomics, it's a major issue in a lot of drug development and so forth. But in safety assessment, this is absolutely as important. Okay? It's the other side of the coin. And it's formalized and perpetuated by statistics that force inference into the two-valued logic of classical math and physics, confusing decision rule outputs with epistemic certainty of truth or falsity, and neglecting the third truth value, which you have to use, for example, to understand quantum theory, which is called uncertain or indeterminate, depending on how you're viewing it, and which, in fact, is the predominant place you should be reaching when you go through all the data and the deductions. This has become institutionalized all over. Go to Wikipedia. I mean, that's the first source of reference from many people, including me. Yeah, so I go to confirmation holism. And it says this. It says one cannot unambiguously determine which theory is refuted by unexpected data. Right? Okay. It means that scientists must use judgments about which theories to accept and which to reject. Yes, that's certainly true in medical science. In practice, these judgments are made according to the outcomes of statistical hypothesis tests. Yes, that's true as an observation of behavior. It's unfortunate, to the extent it's true. But look at this last line. As these have their foundation in mathematical statistics, the methods scientists use to accept or reject theories may be regarded as rigorous. Okay. My reaction to this is utter nonsense. And this is, even if it's not stated as explicitly, as baldly as here, even if this non sequitur is not stated, it is there, I see it implicit throughout all sorts of tutorials on statistics that I see for medical researchers, even social science researchers and so forth. Okay. Now your literature, I don't know the end on it. Maybe it's more sophisticated, but apparently from examples that were being given, it isn't. So some of it is, it depends on the research team. In risk assessment, statistical testing is most often abused to buttress claims of null support, commonly by treating p-values as posterior probabilities. Even if not explicitly calling them probabilities of the null, you can tell the way people are writing, they're acting as if, they're writing as if they were. Conflating non-significance with no effect or support for the null, even worse, as adding post hoc power to buttress non-significant findings, which is encouraged by certain award-winning philosophers as well as by too many statisticians who do that in practice. And here, well, let's look at some history for a moment. We were warned long ago this. This is from Bradford Hill, and he was referring to the smoking and lung cancer controversy. The fact that this was ever a controversy is an artifact, a cultural artifact, okay? There were people, anybody know when the first observation of the connection of tobacco smoking to lung disease appeared? You said late 1940s? Okay, any others? What? Okay, this is a Anglo-American, Anglo-culture, this is well known on the continent here, when I go continent here, a cultural myth of astounding proportion. That somehow Dahl, and big thing, Dahl and Hill should have gotten the Nobel Prize for their study, and so forth. This is absurd. Dahl even admitted he had heard of the German studies going back to the 1930s that found the link using just p-values. It's too obvious to miss. The earliest writing, and I think you can find this online at the James Lind collection for the Cochrane collaboration connected at Oxford, is in the early 1600s. Where King James issued an edict condemning this foul weed, and he was referring to tobacco, saying how the people who had become habituated to this died with foul exudations from their lungs. By the middle of the 19th century, there are articles appearing in popular newspapers condemning it, just for these reasons. By the 1920s, people are looking at insurance records and finding the association, noticing that starting to notice that what had once been a disease called lung cancer, which was so rare that when a case came into a teaching hospital, all the students were called in to look at it, to now something that was becoming common. That it was, by the time you get to the late 40s, it was obvious. There was a clear need for the studies that were done by Winder and Graham, by Dahl and Hill. Why? Because there was tremendous cultural investment in British American tobacco, R.J. Reynolds, because this was a major crop, major export, and it was being recommended, it was being distributed to troops in World War II, it was being recommended for health, for weight control. There was a tremendous establishment there that had to be, and it took decades, overthrown by massive scientific evidence, and no randomized trial could be done. It had to be as tight observational evidence as they could muster, and Dahl and Hill did that, and Winder did his best too, and the American Cancer Society. But it's a relative risk. We're talking about like 10, 20, and so forth. You can't miss it. King James didn't miss it. As soon as tobacco started pouring in from the New World and becoming popular, it couldn't be missed. And yet it was. It was denied. It was promoted as a health product all the way through the 1940s. And it took all the way to 1964 for the American Surgeon General to finally issue a warning about it.
Senator Fisher himself missed it.
Yeah, Fisher himself missed it. Fisher himself denied it. One of the things about eminence, if there is any field that I have seen forget medicine. If there's any field that I've seen that is eminence-based, that has been eminence-based, that constantly defers to authority, goes back and analyzes and looks for clues in the ancient texts of the wise, holy elders, it is statistics. It is an embarrassment. Okay? It is Fisher, Naaman, Pierce, either of the Pearsons, and Jeffries, now that we have Bayesians doing their worship, and DeFinetti. It is pathetic by any scientific standard. Who cares what they said? They're humans. They were fallible. They made horrible mistakes. Fisher was made the most, that's a beautiful example. Horrible mistake. Ridiculous. And not only that, they were fantastic at math. It does not make you good at science. In fact, in some ways, it harms your scientific judgment. This is coming from me. This background is in mathematics. It's damaging because it gives you a sense of certainty which is not warranted in health and social sciences. That's why people are attracted to it. People seeking certainty, but they've lost their faith in religion, so they can find it in mathematics. Let's take a look at comments from a full professor of biostatistics. He's been invited to lecture at Harvard. He's an elected fellow of the American Statistical Association. Over 40 years later, we have this fellow described an estimated odds ratio of about 1.03. Those are the confidence limits. P equals 0.999, of course, right by 1. Said this means that the probability of the observed difference between gabapentin and placebo is 99.9% likely to be due to chance. Now, if you did not get a laugh out of that, you need this talk. Roger laughed, okay? Because this is, or a gas, or something, because this is far and away total nonsense. Now, this is in a litigation case. I was on the other side. This is in a case where we're testifying about these effects. So people say, oh, well, he's just doing this for court. Well, this is where it matters the most. How can you excuse this kind of behavior? This is where it makes the most difference in society at large. Okay? What is that? Let's look at the logic of that, because I see this things like this all the time. This is just very blatant. Okay? What is 99.9% likely due to chance alone? Well, chance alone is equivalent logically to no effect, that would be an odds ratio of 1, and no bias. So the statement translates in symbols, probability, to probability of no effect or bias, given that you saw an odds ratio of 1.03, 0.999. That's what that statement verbally comes down to. But the p-value is actually the probability of observing a bigger association from chance alone. I'm not going to worry about the equals to. That's nitpicking. It's ridiculous. Probability of that the estimated odds ratio is as far away from the null or further than it is, given that there's no effect or bias, 0.999. If you look at the confidence limits, you immediately see that the results support no useful inference. Nobody in their right mind, in this case, thought that any of the effects could be anywhere near a protective level of 1/7 or a causal effect of 8. I mean, we were talking about the difference of whether it was a doubling of risk or not. That was what was at stake. That the data, the clinical trial, this is from the drug company clinical trial data, the drug company data, couldn't prove anything about this safety issue. Not a thing of relevance that we didn't know already. Okay? Now, if statisticians are willing to get up and say this in a public record, by the way, how can we expect researchers to understand things any better in the private setting and conferring with their research team, with their statistician behind doors, especially when they're being driven by the same desires to find, for example, safety for a preferred treatment? Well, of course, what's driving a lot of the bias here is values. What stakes do people have? And values affect all inference. It afflicts all inference. Most often it's nullism. This is a point I've been trying to emphasize, that, and the one thing that attracted me to Bayesian thinking was its open at least the most radical forms, it's open acknowledgement of the subjectiveness of inference. That we're all stuck with our own little point of view, and that's life. We're going to have to cope with that. That so-called objective methods are a myth. Okay? Now, the interesting thing is that Neyman himself knew that, as we will soon discover. And he even wrote that. But somehow everything, what he was taught, when he said objectivity, he meant something very different from how it's taken today. And we'll get to that. Let's call a methodology value biased when it uses assumptions about costs that are not universally accepted, and they're usually hidden. Let's take an example. The consistent use of the null hypothesis as the test hypothesis, failing to distinguish between the two top concepts. And I call that an example of nullism, which is a value bias towards the null. It may be based on imagined costs of rejecting the null, as in product surveillance, or on metaphysical beliefs, as in parsimony, or in ideologies favoring universal nulls, which are rampant, especially the latter ideologies. That nullism has a long and glorious history among physics idolaters. Is a good example is skepticism. This is why I'm anti-skeptical. Okay? I think skepticism is itself a pernicious sort of dogmatic religion. Let's look at some statements. When you go and look at the temperatures that are being reported back by one of the space probes and so forth, you're going to see them in degrees Kelvin. This is what Lord Kelvin said, and he kept saying this in speeches all the way up to 1902 at least. That's recorded in history. What did he say? Heavier than air flying machines are physically impossible. He did the physics, he did the math, and he said they're impossible. Okay? So remember that when you get on the plane to go home from this. Okay? You're in trouble. Okay? Let's look at the current icon of objective Bayesianism. The saint of objective Bayesianism, Sir Harold Jeffreys, who, by the way, he was knighted. He was considered one of the founders of geophysics. Continental drift is out of the question because he didn't say known. No mechanism is strong enough. Same kind. He did the physics. He did the math. He reached a conclusion. The conclusion is starkly, by the time he died, it was considered starkly wrong. And here's another, not from such a renowned scientist, but from somebody much more widely read and known, certainly in terms of numbers. Physics shows that cell phones cannot cause cancer, ostensibly because microwaves are not ionizing. It's from Michael Shermer. By the way, writes beautiful columns, but he's one of the founders of the Skeptic Society, has published skeptics and so forth. This, to me, is the price of skepticism. You endorse your own dogmas, never realizing that you can adopt a skeptical stance from the other point of view and see how completely dogmatic you're being. Now, as a stark general expression of nullism today, consider this 2003 testimony by the now late, Patricia Buffler. For those of you who don't know who she was, remember this, when somebody goes up before a federal court, a state court, Congress, anything, and testifies, people are going to be looking at credentials. People go by eminence-based medicine. Nobody could beat her in eminence by an eminence index that ordinary lay people accept. Former dean, UC Berkeley School of Public Health, member of the National Academy of Science and Institute of Medicine, fellow of the AAAS, published a Science magazine. Here's the testimony she gave on behalf of Baxter Healthcare Corporation, which was seeking to avoid mandatory labeling of a product as containing carcinogens. I was seconded by the University of California to the state of California to comment on this because it was the state of California that was demanding the labeling. Here's what she said. Using the scientific method, your starting assumption is always the null hypothesis. Thus, in epidemiology, you always begin risk evaluation by assuming that there is no increased risk. If you do not observe an increase in the incidence of the disease in the exposed population, then you cannot reject the null hypothesis, that's true, and therefore must accept it. Really? By what logic? It was just commented, academic, that's illogic. That's not logical. Okay? In other words, if you do not have sufficient evidence that exposure to the chemical poses a risk of disease, then you conclude that the exposure does not pose a risk. Okay, what does it mean to have sufficient evidence that it causes harm? If you do not have sufficient evidence. I'll give you an example. If there is no evidence at all, that means that what she's saying is that you should conclude something is safe if no studies have been done. That's what it is logically. This is what's determining policy decisions throughout the US today. By the way, Baxter won their case, thanks to the eminence. Let's contrast this to reality, that in health and social sciences, there is rarely any positive scientific evidence that the null is exactly true. And few specialties have credible mechanistic arguments for claiming departures from the null. Now here's one sensible stat writer that I haven't had trouble finding something where I have trouble with what he was saying throughout his vast corpus. So he's one of the closest that I have to an idol, along with Box, it's D.R. Cox. He said that in many studies, there may be no reason for expecting the effect to be null. The issue tends to be more whether the direction of an effect has been reasonably firmly established and whether the magnitude of any effect is such as to make it of material or contextual importance. Okay? That's what matters. And again, this is in conformity with the falsificationist view of safety. In fact, we have good reason to not believe the null when we're looking at drug safety. In drug development, medicines are pursued precisely because they interact with systems in the disease process. That's why they go after these things and then go put them through all these trials, because they can see that they're having something, or they have a good basis for suspecting that the null won't be true. In fact, they're hoping that it's going to be beneficial. But sometimes, and often, I hear about it all the time, it comes out the other way. And that fact identifies a good portion of the Bayesian literature as null biased. If you know that current objective Bayesian literature, a null spike, which is a massive prior probability placed on the null hypothesis, is used in Goodman's. You've had Goodman speak here. By the way, I would say Goodman, I think he's one of the finest popularizers of statistics for medicine I've seen. And I agree with it's running about 11 out of 12 things he says. But this is one case where when he's wrong, just like when I'm wrong, and I won't see it. Otherwise, if I saw it, I wouldn't be wrong anymore, right? I would change my opinion. You're wrong because you don't see you're wrong. He was relying on these authorities, Berger and Selke, and who were in turn taking their things from Jeffries. It was Berger, Jim Berger, who, when I'm talking about these things, he invited me to. That's why I'm going to Duke in a few weeks to present exactly on this topic. Okay. What it does is that it creates wildly overconfident inferences when there's no conceivable data or accepted law that could prove the null. And this is why spike leads to inferences inconsistent with falsificationist methods such as Neyman-Pearson testing, which are also null biased, but for cost reasons, not on scientific reasons. This is why I'm starting to think that some Bayesian methods, those being promoted with the null spikes like by Donald Berry, I noticed Berry's name, I think it was the same Berry, came up, I think are actually potentially, they're starting to show up as more damaging than the classical statistical testing. Because they load the null with non-existent knowledge, false knowledge. Often, even effect probabilities concentrated near the null have no valid derivation from available data. Again, in drug development, that's the case. And still, many scientists and statisticians exhibit quite a bit of prejudice in favor of the null based on faith in oversimplified physical models of biology. Shermer was an example by claiming cell phones causing cancer is physically impossible because microwave radiation is not ionizing, as if ionizing radiation is the only carcinogen. Not that I think cell phones are carcinogenic. I'm just saying we don't have the kind of safety assurances like that. We can say it's physically impossible. Now, nullism also arises more subtly from confusion of decision rules with inference rules and from adoption of simplicity or parsimony as a metaphysical principle rather than as a heuristic. We might be highly certain that any effect present is small enough so that the costs of ignoring it is acceptable, or that its costs are less than the costs incurred by acceptable alternatives, like, for example, resin, although we don't know that yet. But outside of pure finance, these are value-laden judgments. In pure finance, we're just dealing with the dollar sign, both ups and downsides. But for the rest, it's like, how do you want, often, as I said, as Ken Rothman said to me when we first met, and he prepared dinner, and I was kind of grumbling about the food contents. This is in 1977, and I was already going through my health food phase. He said, Sander, well, he's rubbing the cheek. He said, don't you know living is choosing how you're going to die? Okay, it's choosing your poison. This fact was well known to Neyman, even though forgotten in most statistics training and usage. Let's look at what Neyman said. I'd have to say this because, again, I actually knew him. According to circumstances and according to the subjective attitudes of the research worker, one error may appear more important to avoid than the other. The error which is the more important to avoid will be called error of the first kind. The hypothesis, the unjust rejection of which constitutes the error of the first kind, will be called the hypothesis tested. Now, he was actually working on this when I was at Berkeley. What I want you to note about this quote, which might seem unremarkable at first, but it does cause gasps in some audiences, is that, first of all, according to the subjective attitudes, he knew the subjective elements entered even into so-called objective statistics. Okay? But the thing that I want you to note is that the hypothesis may be non-null. There's nothing there that says the null hypothesis is the hypothesis to be tested. Nothing there that says that's the error, false rejection of the null is the more important error to avoid. Because it doesn't belong there. It's not there because it doesn't belong there. And he explains why. From the point of view of the manufacturer of a chemical A, the error in asserting the carcinogenicity of A is, or may be, more important to avoid than the error of asserting A is harmless. Thus, for the manufacturer of A, the hypothesis tested may well be A is not carcinogenic. On the other hand, for the prospective user of chemical A, the hypothesis tested will be unambiguously A is carcinogenic. In fact, this user is likely to hope that the probability of error in rejecting this hypothesis be reduced to a very small value. What you're seeing is that in the original founder of statistical hypothesis testing, there is no nullism. In fact, there's even a caution against it, of saying that what you choose to test is going to be based on where your values, your cost, your stakes, your vested interest, your conflicts of interest lie. What is it that I see? How often do I see a non-null tested in tests of differences between groups? Well, in the risk assessment literature, in the safety, what I call that in the medical literature, this is how often I see it tested, okay? That's none of the time. It's always the null, the null, the null, the null. It's just like that safe, safe, safe in the ADA. That's nullism, and that's a bias against the consumer for the manufacturer in that example. Not only that, but multiplicity adjustment in safety testing expands this bias towards the null. It takes the joint null as the test hypothesis, the one more important to not reject incorrectly, using the standard type 1 error rate of 0.05 for the entire ensemble of nulls. What does this do? These tests assume increasing relative costs of type 1 error over type 2 error as the number of hypotheses being tested increases. It assumes that the expected cost of any false positive is more than the expected cost of any false negative. This valuation is likely to be true for drug companies monitoring adverse effects, but very false for patients.